Right. Go ahead and call the meeting to order on this icy cold day. So we will start with the minutes. Any comments, changes, or corrections to the minutes?
No.
I move the minutes be accepted.
Second?
All in favor?
Aye.
Opposed? And so my understanding, Pat is not there yet, is that correct?
That's right.
Should we hold off this report till he gets there, or does Jeremy want to give a report, or?
We should do the liaison updates, and then Jeremy can do the director's report if Pat's still not.
Okay.
Why don't we go ahead and do liaisons, and then I'll come back and do the director's report if Pat's still not here, which I'm happy to do.
Okay. So the committee digest is in your packet. Do we want to have liaisons give reports to add to these, or make any comments about the reports?
Carlos?
David, I know you're there.
I have a few comments, and I'm going to interject whenever you think is appropriate.
Okay, David?
You good? Okay. I wanted to make a few comments, bring a few comments back from FAB, and regarding the translation of our approved policies into the RFA language for CCO 2.0. As we were here, we heard several recommendations from FAB about using local health authorities to leverage investments in social determinant of health, and with the goal of moving health promotion out of the clinic into the population. And we had discussions about leveraging community-based organizations, which I think are do heroic and really important work for vulnerable populations, and also local health authorities. And I think local health authorities are slightly different than CBOs in that they're really the only agency that's charged with true population health, meaning health of the entire population. And we're seeing the importance of local health authorities today in response to the measles epidemic. You know, there's no CBO that's going to be able to address measles at a population level. And I really think that the buck starts and stops with population health at the local health authority. And as I was really pleased in our deliberations that we approved several policies that reflected this intent. There was policy number 1 that required TCOs to spend a portion of savings on social determinants of health, population health policy and systems change. And while this policy doesn't really call out local health authorities, really there is no other mechanism for population health other than working with local health authorities. There was policy number 3 that encouraged TCOs to share financial resources with non-clinical and public health providers. And that this sharing of resources would require, this isn't in language, but implicitly would require some type of formal relationship between the CCO and the local health authority. And there was a policy number 8, which required CCOs to partner with local health, public health authorities, nonprofit hospitals, to develop shared community health assessments and community improvement plans. So while this was in the policy, we discussed this, we came up in the FAB committee that some of these policies weren't really reflected to our best understanding in the actual language of the RFA. And I think there was a few letters sent to OHA in the public comment from FAB members. And I've had some correspondence with Lori, who's been very helpful. And it appears as if that language was meant for some appendices and supplements, but that hasn't yet been posted. I think that these policies and the translation into CCO 2.0 is really important because, as you all know, we have the most expensive healthcare system in the world with the worst outcomes. And that's not so much because our healthcare system is bad. We have a really great healthcare system technologically. There's really important improvements that can be made in terms of the health system and health policy. But the reason we have the worst health system, most expensive health system with the worst outcomes, is that we don't spend on social determinants of health like other countries do. They spend as much as we do we spend as much on healthcare as they do on social determinants of health. And that's how they get better outcomes. So now we're in this situation where we have these policies, at least I haven't read all the RFA, but I sort of looked for the language and didn't quite see this articulated in the way I thought it would be. But now we're in this public comment period. I understand that communication around the RFA is restricted in public comment. And I just wanted to talk with OHA in terms of, is there a remedy, and how do we sort of reconcile this disconnect between the policies and the RFA?
Yeah, so let me dive in there a little bit, and some of this we might need to follow up more offline, but so we're actually not in a public comment period, so we've actually released the formal RFA. We did release a draft on January 4th. Had a public comment period for about 2 weeks. Received, I don't remember what the total number of comments was, received a lot of comments back, including comments from counties and local public health. We went through and reviewed all of the public comment and did make some changes to the RFA. As a result of that, we didn't accept all the changes that were suggested, but we've got a list online of where we made changes, and then have released the final 2 Fridays ago. So the final RFA is on the streets, as well as you alluded to. There were some documents, some supplemental documents that weren't included with the original draft, including community engagement plan expectations of how CCOs would work with local community partners. So some of it is in there, and I think wasn't in the original draft, but is in some of the final details that were released as part of the final RFA. So the RFA is on the streets right now. There were a number of comments that we received around from counties and local public health around requiring CCOs to have contracts with local public health, requiring counties to have letters of support. We considered those, ultimately decided that what's in the current RFA around requiring memorandum of understanding accomplish the same goals of really requiring CCOs and local public health to work together on a number of things that you outlined. So we didn't accept those changes, but we did go through and make some other changes, and including, I think, a couple related to local public health. I have to go back and take a look exactly what those were. But the final RFA is on the street. I think there are some more documents that some of this was in that wasn't in the original draft, and happy to try to follow up on any other specific questions. We are in a formal procurement process now, and so really all questions, everybody needs to be getting the same information, and so I recognize this is kind of awkward spot for the board to be in, because you are our oversight board and policy setting board, and we want to be responsive, but we also want to make sure that everybody's getting the same information in terms of what's required of the RFA. So I think if there's more specific questions, we will take those, funnel them through our internal process, and then respond in a way that everybody can get the same information, including FAB and the board and others.
But so is there a mechanism to close this gap, or at some point?
Well, I think first you understand if there really is a gap in terms of, there wasn't it sounds like some of the comments that were at FAB were without all of the final documents being released. So I think folks need to probably go back and take a look at all the final documents, figure out if that's still a concern. Okay. And then if there is, we can go back and take a look at that. But I mean, just to be blunt, I think there might be a spot where we just did not land in a spot where there's agreement between exactly what local public health was asking for and where we thought the board was at and where the RFA was at. So if the idea is require contracts, we've considered that and decided not to pursue that, to stick with the memorandum of understanding language. But if there's other concerns within what was in the final recommendations, then I think we should probably talk about that.
I'm concerned with that. I think that is a gap, and I think it's a gap and is inconsistent with the policies we approved. And I think it's a really important step forward in terms of how we implement the policies we discussed into actual contract language. So I hope there's opportunities to close that gap, either at some point in the process.
Yeah, and I think again there is a MOU requirement which captures a lot of the expectations in terms of how a CCO operates with the county. The fact that they have to have that agreement, they have to describe how they work together, and there's pieces of that in the community engagement plan too. So happy to pull those out and see if that gets at, I think, what your concerns are.
Okay. All right.
Just listening, and seeing where we're at in terms of the CCOs. I mean, I think there is this tension between counties. I mean, when you're talking about local health, it's mostly county health departments, right?
Yes, yeah.
And so there's this organizing infrastructure by county that in CCO 1.0, we pretty much ended up with almost a 1-to-1 correlation between the two. Who knows what will happen in 2.0? But I could see that, imagine there's 7 CCOs trying to deal with one county. And I would agree, I think that county health folks, they are the closest to the health of the population. So there's a tension there that could get interesting, you know, in 2.0, and I think it's an important issue.
And I just want to be clear, we've recognized that relationship, and there's a number of things in the RFA that point to the relationship between the CCOs and the counties. So I think if we can pull those out specifically for the board, happy to do so. We just need to do it in a way that, again, everybody's getting the same information, including the board and the public. So we'll work on that.
So, but we have to we approved the policy, encourage CCOs to share financial resources with public health providers.
Encourage is different than mandate.
Mandate.
You know, and I actually support the idea of giving the local communities the flexibility and not being required by the state or kind of hamstrung in a particular way that they're actually required to do that work. And I say that from the perspective of being a fan of public health and recognize the population health impact that you're describing. But I think that's a really fine line. So my question to you, Jeremy, is does OHA have technical assistance where there are communities and best practices when CCOs and public health authorities or local health authorities are really collaborating well together, and there's some best practices in that kind of conjoined space that other communities could learn from? Or where there may be tensions that are kind of underpinning, I think, part of what we're discussing right now that could be resolved. And maybe this is downstream, I'm just curious what kind of supports there are.
Yeah, absolutely. That's the role of the Transformation Center, and they absolutely can play that role and will play that role. And I think you're right in terms of the courage versus requiring a contract and what those two different things mean. So yeah, the Transformation Center certainly can do that. I think we're recognizing also that the county landscape is changing. It looks different now than it did 5 years ago. We have a couple counties now who have basically relinquished their local public health authority. And so we're trying to strike a balance too, recognizing not every part of the state looks the same right now in terms of even what the county's role is.
All right, thank you. All right, Carla, thank you for your time.
All right. I just want to check and see if Oscar or Rosinda are on the phone.
Yes, Rosinda is.
Okay. So, John, I believe you have one of these committees?
I think there's a sheet that was available in addition to the packet. This is a communication from me, and as part of my perceived responsibility as the liaison to the Health Plan Quality Metrics Committee, we're talking more about the role of liaisons. And recall, actually, at last meeting, there was a communication from the HPQMC to the board, and in the brief discussion around that, it was suggested that there be more overt suggestions on my part, and that the communication come from me as the liaison. So this is it. And there's 6 suggestions, and I'm not going to go over in detail, but let me just move through quickly. I think what the committee is trying to do here is point out gaps or issues that they've noticed in their work. In many respects, this goes back to, this is the Health Plan Quality Measurement Committee. So that they notice things going on in other realms of measurement, in addition to health plan, and are trying to point those out. The first one's the easiest. There's no oral health representative. The legislature didn't include an oral health representative. They're asking for one. And you know, I think that's a reasonable request, and we should endorse it and ask that OAH figure out whether that needs to be in a bill or those sorts of things. numbers 2, 3, and 5 essentially point out gaps. There's no longer, as far as they can see, and I would agree, a place where hospital quality is overall being measured. And this is especially important because there's a very robust group of maternal and child folks who came to the committee saying, Jesus, it looks like you're doing great stuff. We've got a lot of ideas about how to measure maternal and child performance, but many of them are inpatient measures. And so the committee had to, for the most part, pass on that. So they're pointing out there's a gap there that deserves some attention. It's a tricky one, but I think it's worth more discussion. There's a gap when it comes to clinic level measurement. They see plan measures that are very relevant, but it's not in their purview to weigh in on which of those should go down to a clinic or good clinic level measures. The Primary Care Payment Reform Committee is working on the same issue, and when we get to that report, which I think has been sent out, we should remember that there's a question about, well, who should be weighing in around measurement when it comes to primary care clinic performance. The fifth one is interesting because the gap is around employers who may be self-insured in the commercial market. And that's been a chronic problem, that piece is going unreported and is relevant to the cost issues we're going to eventually be discussing. How will that be measured and evaluated? So those are three important gaps. Number 4 is, I think, a relevant concern. There's a lot of performance stuff headed OAH's way. And an observation that we're using up a lot of OAH resources in developing new measures around kindergarten readiness and really great stuff. But that's going to eventually need to be addressed. And then in 6, how is this going to all come together, if it should? Because, I think in this state there's a lot of believers in you can't improve what you don't measure. So folks are all measuring stuff all over the place. And, will there be a structure to bring this all together? OHPB has kind of said it's us, but this is going to get really tricky. And we'll talk about it more when Jeff talks about the structure diagram that's in the packet. Other than the oral health representative, I don't think there's anything that we need to do today. And I'm not sure if that needs a motion, I'll make it. But I'm not sure it needs a motion. But I think it's just a robust effort on the part of the committee to give you their sense of what's happening in the universe they're surrounded by. Okay?
I have a question for you.
Comment?
So you said in items 2, 3, and 5 that you're recognizing and that the committee is recognizing the gap in terms of how hospitals are being measured and the systems around that and how it's integrated.
In 2.
In 2.
Yeah.
Can you speak a little bit more about the remedy that you think that we should be paying attention to?
Not much, because I don't feel very informed about what actually is going on.
Okay.
And I'm biased by my experience from 20 years ago, which obviously is out of date. I think there's multiple measurement efforts going on around hospitals. Leapfrog is measuring hospitals nationally, and CQA, maybe to some extent, is the safety folks, I think, are doing measurements. But there was an existing system that brought all this together that disappeared, was not part of the plan going forward as of a couple years ago, and so it's been dissolved. And it's a huge performance area. So I don't feel qualified at this point to suggest a solution, that's why I think it's important that there be an effort to figure out from folks involved what's going on here and what should we do. Especially in terms of maternity and child stuff. I mean, if indeed we're committed to maternity and child, then you read this report from a stakeholder group of folks who work for many of the hospitals and health systems. Of course, many of the big issues for the most at-risk children occur in a hospital setting.
Yeah, I was thinking about our retreat discussion and the total cost of care conversation that we were teed up to consider
Right.
as a board. And this seems like another one of those areas to you, Jeremy, around ongoing board education for us to understand the systems themselves and the underpinning data that we have that's already available to us to focus our attention.
Yep, absolutely.
Any other comments? Don, I think this is a lot to take in. I'm just kind of looking at it, and it might be worthwhile for us to, I'll work with the staff and see if this is something we might want to think about putting on the agenda next time also. Because there's a lot of information in here. You're as thorough as usual, John, so thank you.
Well, thank you, Carla, but let me give credit where credit is due. This is coming from really the committee, who is up to date and who is representative and who I am impressed is top rate and knows what they're doing. And the two co-chairs are terrific, and I'm just trying to be a mouthpiece. I'm just trying to be the messenger.
And we will not shoot you. The opposite of John, the Healthcare Workforce Committee report is in the digest. I do not have anything to add to that at this time. Any other comments about the report regarding the committees? Okay. Let's see. So did Pat join us yet?
Nope, I can give a quick update. If Pat shows up, we'll have him update more, but you want me to dive in, Carla?
Yes.
Great. Some of this I already covered, so as you know now, the final RFA is out. We did do a two-week public comment period, which I think was a really good call, and we received a lot of great feedback, and went through, did some work sessions and worked through and made a number of changes to the final RFA that went out, including things that were just errors or version control issues. So I think it was definitely a good reason to do a draft and then a final. On Friday, the next step after that was letters of intent were due on Friday. I think you all know now that that period is closed, and we received 24 letters of intent covering the entire part of the state. These are binding letters of intent where they have to describe what their proposed service area is. And then the next deadline is April 22nd when applications are due. So not every organization has to file an application because they filed a letter of intent, but the letter of intent, if they do file an application, it has to follow the letter of intent. There's a short window here for the next couple of weeks where adjustments can be made to the letter of intent. And we expected that once we made those all public, that folks may want to come in and make some tweaks. But overall, we're really pleased. A couple of things. One, the entire state is covered with the letters of intent, and knowing that we don't see any pockets right now where there's folks who wouldn't be covered by a CCO, and that's great news. All but one, the current CCO has reapplied, and as well as a couple organizations who are looking to expand or change. So they're just really, really pleased. Despite some media stories over the last year around what's been going on with CCO finances and things that the board's been tracking, I think shows that the system is really robust, that this is a market folks want to join, and that the work that we've been doing as a state, that the direction you all set as a board, is one that folks want to be part of, and that's all great news. You know, you kind of wonder if you build it, will they come? And I think this was a great step, that the work that you all did over the last year is really pointing us in the right direction. So we're really pleased. Like I said, there could be some changes over the next couple of weeks, and then the next step will be applications will be due on April 22nd. I should just note, I guess, a couple other things. Lori Coiner, our new Medicaid director, has started last week, so we're very happy to have her on. I can't remember if Pat gave the update at the last board meeting. Dave Baden joined us as the new chief financial officer, which is great, and then within HPA, Trilby DeYoung joined as the HPA deputy director. So I'm feeling very happy about where we are within the agency, of having a whole bunch of new hands on deck, and great folks who are really smart and going to add a lot of value to the organization. So really excited.
How are you recruiting a behavioral health director?
So I should mention that as well. So recruitment's still underway for a behavioral health director. John Collins, who is our health analytics director within HPA, has rotated over and is serving as the interim deputy behavioral health director. As Mike Morris, who was the interim behavioral health director, has now retired, or is retiring this week. So John will be on a rotation over there while we finish that recruitment. Somebody else on John's team, Stacy Schubert, who we met in January, will be backfilling John's position during the transition. So still working on the recruitment.
Do you have a pool of applicants that you're reviewing?
We have had pool is probably too strong of a word. I think we've gone through a couple of pools of folks, and have gotten close a couple of times, and for a number of reasons hasn't quite worked out. Keep getting close though. So hopefully
I'll start shaking
we'll
some
land
trees.
the plane soon. Yeah.
Oh, John?
Yeah.
Yeah, Carl can see you.
Yeah.
Carl, John's raising his hand.
I read in the media that there is a significant variation in the performance of CCOs now, in terms of bending the cost curve. I'm just wondering if at some point there'll be some discussion here of what's going on there. You know, what's led to that variation, and what's occurring as a result of it. And, you know, I can't help but wonder, well, 2019 is a transition year. What happens to performance that's not optimal in terms of bending the cost curve if it happens in 2019? Who's held accountable for that? Especially if it involves a CCO that isn't continuing, isn't successful, in the 2.0. So I don't need anything today, but I think that's something that would be good to discuss at some point.
Yeah, certainly as we're thinking about the cost work plan and trying, I think in particular an area that's interesting to see is if there's similar trends across CCOs, PEB, OEB, the other commercial market, whether this is, if there's trends within CCOs that are isolated to CCOs, or whether there's commonalities across the markets. Some of this I know is old news, but we know, pharmacy's been a challenge. We know that in parts of the state where there's been more aggressive value-based payment arrangements, especially with hospitals, have been the places where they've been able to come in under the 3.4% or even in a negative trend. So we've got some data points there, and certainly without going into all of the CCO 2.0 policies, one of the things that we're advancing and that will be part of legislation in this session is to increase the line of sight on the finances as an agency, so we can do a better apples to apples comparison.
Right. And you know what? I don't know what the impact. I listened to is it Secretary Azur, and he's going to get rid of rebates in Medicaid and Medicare. I think that's what he said. And Warren, well, that's going to increase costs in the short term, but it's going to come back to benefit individuals. Okay, but what does that mean for CCOs? I personally am not a fan of rebates. I think that's a pretty corrupt mechanism. But hang on.
I'm curious about what you'll be updating this board, like the quality of the RFA process throughout this next year. So I recognize, having said that or asking the question, there's a lot you can't disclose while you're in the midst of it. And, you know, what is your process or your thinking about how you discuss it more?
So we're anticipating we'll give you regular updates like I did today. I mean, like you said, we're in the middle of the procurement, so we can't be sharing confidential information while we're in the midst of the procurement. So those updates I think will look a little bit different. I mean, we probably won't be a lot to share between now and April 22nd when the applications come in, but certainly once the applications are in, you know, I anticipate we would give you an update in terms of who applied. There'll be a number of steps following that, including sort of a readiness review process, you know, how to think through member transition issues and open enrollment. So I haven't really mapped out exactly what updates come in what month, but anticipate we'll keep giving you regular updates as we progress through the process.
And when you have multiple applications for a single area, what's the evaluation and decision process look like? You evaluate based on cost, quality, coverage,
So
all the above?
Yeah, so I really can't get into the conversation directly about what the evaluation process is going to look like, sorry.
All right.
I can tell you that we'll be evaluating, you know, each application consistently, but we can't get it right now in terms of what the process is going to look like.
Can I ask one other question? I mean, I've heard the last couple of days and this morning about the topic of disruptive children in the schools. And, you know, I'm reminded of some of the conversations we've had about mental health in children, behavioral health in children. And just such I think, an opportunity for schools and CCOs and OAH to get lined up. Because I'm betting that, well, I mean, one report I heard said that, you know, there's a small group of children who have mental health and behavioral problems. And, you know, a lot of resources over here that could help them. But I know from when we went to Astoria that there's, you know, these silos between the schools and health and all. And so I assume OAH will be part of that discussion eventually that happens around what can be done to help the schools in terms of those children.
All right, are we ready to move on to our report? Is John and Leanne there?
They are. While they're coming up,
Yeah,
honestly,
Sean.
I recognize this is an awkward spot for the board being in procurement. It's just we need to be really diligent on our end in terms of what we're sharing with whom and when, and make sure nobody's getting a leg up in the process.
You know, I'm comfortable with the discomfort or the not knowing the ambiguity. My recommendation would be a timeline for
Sure.
disclosure and whatever, you know, people can anchor into that.
Absolutely.
Yeah.
Happy to do that.
Yeah.
You better make a good decision. I know you will. Carla, Leanne's ready.
Good morning.
Okay.
Good morning, Chair.
Good morning.
And members of the commission, board, pardon me. My name is Leanne Johnson. I'm the Director of the Equity and Inclusion Division for the Oregon Health Authority. I believe John Collins is on the phone. Is that correct, John?
I am.
Okay, great.
Yeah, I'm on the phone.
Okay, thank you so much. So I'm going to go ahead and take the lead, and John has a lot of relevant information as well. We wanted to provide to you an update on the work related to health equity metric for 2020 and beyond. So as you may recall, John and I reported, I believe in Albany, that we were pulling together a committee from a variety of, representing a variety of committees and work teams within the Oregon Health Policy Board structure, as well as the Oregon Health Authority. And we have met 5 times since October and have a pretty major task before us. And basically the way I put it is we're trying to do it in 4 months, what couldn't be done in 4 years. And I want to commend the committee and the work that has been done and the researchers that have helped to move our thinking forward on this. So I also want to make it really clear that we are looking both at a short-term metric for 2020, but this committee is committed to look beyond that, because the realization is that what we can accomplish in 4 months is not anywhere near what we can accomplish, this team in particular, what we can accomplish in the longer term. So I want to report at this point in time that we are working on a process measure as opposed to an outcome measure. And I understand that that is a controversial, and there's tension there around taking that approach. But I will tell you why in a 4-month period we have decided to focus there as opposed to a specific outcome measure. We, as a committee, had a variety of conversations around the current status of race, ethnicity, language, and disability data, in that collection and where that sits. We also had a variety of conversations, and John could speak to a greater degree on some analysis that was done around an outcome measure to see how it, and I'm not a researcher and analyst, but to see how it held up across all CCOs, given the service areas and the demographics of those service areas. So we, where we landed was to focus on a process measure at this point in time that was reflective of 2 primary areas, traditional health workers as well as healthcare interpreters, language access. And we have not arrived at specifically how the measure would be articulated, but looking in those 2 areas. The reason being is that, number 1, it does, at this point in time, not rely upon the race, ethnicity, language, and disability data. I'm happy to talk at another time as to the work we're doing to rectify the situation of the fact that we don't have all the data that we need around race and ethnicity, language, and disability in the system. And there are reasons for that. There are technological reasons for that. We've done some research on that, and we are now proposing recommendations to fix that. So, but that's a different conversation. So I wanted you to be highly aware of the fact that that we have researchers and very good people working on that issue, and looking towards more updated and accurate and thorough information as we move into a longer term conversation about what these measures can be. It's also important to note that in a 4-month period, we're not going to be able to vet a measure with the people that are most impacted by health disparities. So it was very important that we did not fall into creating unintended consequences for the communities that are most impacted by health disparities. And it was important that we move forward with something that was already being pushed by the community. So both language access, we heard about that in CCO 2.0 community engagement sessions. What's happening with that? What are we doing? How do we have greater utilization of healthcare interpreters? Also, how do we have greater utilization of traditional health workers? And that was something that was pushed by the Traditional Health Worker Commission, which is a stakeholder-based commission. So it was important to us that we moved with initiatives that were already being pushed by the community, since we're not able in a 4-month period to do the appropriate vetting of that. And when I talk about the unintended consequences, I just want to put an example out there of what this could mean if we jump to an outcome measure. So let's just take, for example, this is not to slam anyone who's using this measure, but let's just say, for example, that we're using smoking cessation as an outcome measure. What we need to take into account with that measure, and this is research that the Office of Equity and Inclusion is doing in conjunction with Program Design and Evaluation Services, because what we want to do is be sure that we are doing an equity analysis when it comes to outcome measures. So actually, we have been working with Program Design and Evaluation Services to get a better understanding of how racism, as well as ACEs, how that impacts outcomes. So if we go to smoking cessation, just as an example of an outcome measure, and don't take into account some other information. So when we look at, for example, the African American community and smoking cessation, that we see that when you have when a person has 4 of the ACEs, smoking prevalence goes up in that community. When you add to that then an incident of racism within the last 30 days, it goes up even more. So smoking prevalence and smoking in that community doubles based upon those factors. So if we're going to, we've got to get people to stop smoking. We cannot get to an outcome of that if we're not addressing ACEs and if we're not addressing acts of racism. And those are addressed through process measures. So if we're talking about truly wanting to dismantle the foundation of a system of systemic oppression, systemic racism, we've got to look at the initiatives and the strategies that will help to do that. So if we take that concept and apply it here, when we're looking at process measures, what we're looking at is culturally responsive care for communities that are most impacted by health disparities. So that's why in the short term, all these reasons are in the short term, why we're going to that type of a measure for 2020 as opposed to an outcome measure that is not fully vetted and where we do not have an analysis of what the unintended consequences may be. It's really critical important to the committee from a standpoint of ethics that we not rely on an outcome measure where we don't have full or the fullest data that we can have and where we have not tested for unintended consequences in that. So I'm going to stop there and see if John would like to add anything and then open for questions.
John, are you talking? If you are, we can't hear you. We lost John.
You lost John?
Well, I'll just say, I know Leanne's hedging a little bit because the work that she referenced in terms of sort of researching what's been going on is still sort of somewhat in a draft form or internal, but I kudos to Leanne and her team, Marjorie and her team, who have done a ton of work. I know the message the board has been hearing is we've seen a big drop in real need data, and we don't really understand why, and it's a problem, but her team has actually done a pretty big deep dive and to try to understand that, and it's, you know, it's a challenge, and there's not one real particular reason, and there's not one particular solution. I mean, it really is a lot of different things, including different IT systems trying to talk to one another who don't have fields that match up, and so the data is getting, you know, eroded from one system when it's transferred from one system to another, which creates validity issues. So those are the types of things that I think folks have been grappling with when they're saying we don't have great data, we don't have, you know, data we really feel is reliable in order to go into this space. I think we finally have, you know, a better understanding of what the causes are, what some solutions are, to try to, you know, make sure that we can start ramping back up our race and ethnicity data collection, and it's going to take some time and it's going to take some work, but I just want to say kudos to Leanne, because I think that's been really responsive to the board's you know, concerns over the last several meetings of trying to understand. It's not good enough to say we don't have good data. We got to figure out how we increase the data and make sure that it's valid, and figure out how we can, you know, comfortably enter the space of building out some equity measures.
Even if you did have an outcome measure that you all everyone agreed on, which says we're not there yet, without the race ethnicity data, that would be uninterpretable.
That was the concern,
Yes.
absolutely, yes.
Yeah, I mean,
yes.
I think, you know,
Yes.
they're getting the predictor data, you know, I think it sounds like it should be priority number one.
Yes.
Even before process measure. I mean, I'm glad you have a process measure. It sounds like a sensible approach. I look forward to an outcome measure such that can be incentivized, but
Yes.
in order for that to have any meaning, that the predictor data needs to be complete.
Yes, and we kept in the committee, no matter how many times and how many routes we took, it always came back to that. And and we're looking at, we have 5, and like I said, I think certainly Jeremy has done a great job in highlighting the report, and happy to do a deeper dive with the board on that. We've put forward 5 immediate recommendations to help the issue along, if you will. One of those 5 has already been implemented, and right now we're in an open, and I don't have the right terminology, there's right now within the one system and the IE system, we have an opportunity right now to make some of those changes.
Is there a work plan and a strategy in terms of, to get that data to a place where it's analyzable?
I'm sorry, before you move
We
on.
don't have to go back.
Carla, what was the last thing you heard?
We don't hear you.
Carla? Carla?
Leanne was talking about smoking.
Thank you.
Right?
Oh, it is.
And I think that was most of the presentation until we got to the questions.
Questions, yeah.
Right?
Yeah.
And the questions was, run a work plan
Right,
to
right.
get the predictor data.
Absolutely. So, so the report is relatively new. There are, in the overall report, though we've prioritized 5 of the recommendations, there are 14 or 15. Pat, Jeremy, and I meet next week, and I think the work plan will be an ideal topic for that meeting. And then I also believe that having accountability with this board on that work plan would be very helpful as well. So I think what we should do is commit to you to bring back a work plan, whether that be, I don't know that if that will be March or April, but I think that that would be a really good route for us to take and to work this together and have that public-facing accountability around this.
And not, to not get into it, I mean, I think this is actually, better for an actual longer conversation when we
Yeah.
can lay out everything. But there's, strategies in there that are things that are somewhat, workflow and getting folks, getting workflow better for folks who are entering the data to
Right.
IT system changes that are much bigger and larger and probably longer term. And so there's a whole mix of things that I think we want to, run through with Pat and then
Yeah.
figure out how do we, prioritize which things move forward. But it's going to be one. I think we've got information, actual information for the first time, but 2, it's going to be a long haul. So we're going to have to be sort of building metrics at the same time that we're also trying to increase the quality of the data.
So is a work plan on reliability, validity, and completeness of race, ethnicity data and outcomes, or just,
I would, well, and maybe that's.
are those 2 separate work plans, or are they?
When I heard the question, and when my response was related to a work plan for improvement around race, ethnicity, language, disability data. That's what I was
Okay.
responding to when I understood the question. And I think that having those recommendations in place is the starting point, and now what we need to do is map that out with timing and resources.
Okay. But they're kind of 2 parallel tracks. I mean,
They're-
that's
absolutely.
the data collection piece. What the work group is working on is the measures, right? And
Right,
so
yes.
that works on, on a timeline, as you can see here. And what we have to do as an agency is also increase the quality of the data at the
Right.
same time, so that the measures can be valid and improve over time.
John?
Yeah,
So this is Carla. So I guess I have a couple of concerns. One is, as part of the charter for the committee was to also make sure we address disparities related to geography. And there, there's a lot of data and studies related to health being related to your zip code. And so I think it's really important that we, I know we can pull data by zip code, and I think it would be really interesting to look at that data and look at the state and see where we're noticing these disparities. The pushback I would put on the example of the smoking is, I think you're going to find disparities in smoking geographically. And the causes for those disparities may be different in each zip code or variety of zip codes. And one of the things that I have found in working with the metrics that we have put forth previously is I feel like the CPOs have to identify why those metrics are not being met, and to help local areas to facilitate what needs to be done in order to help with those. And so I think this question about how you address underlying issues is something that needs to be addressed within those CCO's purview that are addressing those zip code areas. Does that make sense?
Dr. McCullough, thank you. I understand the observation and the question. And what I would say to that, number one, is that regarding the example, our primary concern was around unintended consequences for around race and ethnicity. This is why we use this example, and it was not intended to be an across-the-board example, but it's very relevant to race and ethnicity, and that's why it was important, because the committee was very clear that they did not want to have unintended consequences on populations of people that are most impacted by health, social inequities and health disparities. That said, then when we get to zip code, yes, there are absolutely, zip code matters, place matters, and then also when we talk about zip code, we still have within any zip code, within any urban or rural, within any socioeconomic class, you still find within that additional disparities as it relates to race and ethnicity. So, so some of those, for example, education or economics, wealth, do not necessarily serve as protective factors because you'll still, if you compare across the board, you will still see disparities around race and ethnicity.
Hey, can I chime in real quick?
Yes.
Yes.
Yeah. And I just want to emphasize, and I know I missed part of what Leanne had said earlier, but to kind of piggyback on what she was just saying, we can definitely drill down into various metrics by zip code and various other geographic breakouts. The real issue, and it will continue to be an issue until the data, the source data from MMIS is fixed, is that missing information. As long as we're missing roughly half of any kind of information around race, ethnicity for folks, we will have a hard time coming up with any kind of valid measure associated with it, and would be hard pressed to really have the CCOs work on information that is really only half there. It's like having 10 bills in front of you of currency, and only half of them are labeled, and somebody asking you how much money you have. If you only know that you have a few $1 bills, but then the rest of them you don't know, you can't guess. So the approach that we're taking with this qualitative is really kind of a strategic approach, in addition to, it's not really just this is the only thing we can do. It really is focused on making sure that some of the infrastructure that would be necessary to address any kind of equity or disparity concerns is there, and hopefully we will be able to follow that up shortly with some data.
John? Yeah, two questions. My recollection from an earlier discussion was that I think some CCOs asserted that they did have sufficient data. Do you know, is that the case?
They might have some data from their clinics.
Because the reason I ask kind of relates to the second issue. Is it possible, I mean, I'm good with where you're headed, and I think it's reasonable, and I understand it. Are there some islands of good data out there that would be useful, and from a pilot point of view, to start to test, some of these other measures? That's number one. The other thing I think I've expressed concern, we're on the verge of, implementing transformative stuff, whether it's CCO 2.0 or the cost stuff. And the skeptics of those transformational activities are going to be worried about equity. They should be. The problem then is if you don't have a baseline from a fee-for-service dominated system, they could claim, gee, this is inequitable. Well, that's because you have 1 point and you don't have 2 points. And my own belief is the fee-for-service system is as inequitable as you can get, and has contributed to the problems we have. So I'm just worried that if there's a way to save a sample or, you know, have some way to look back at 2019, 2018, 19, et cetera. I think it'd be really important.
Thank you, and I will let John had started some, yeah, go ahead, John.
Yeah, well, a couple things. So to the first point that you were making, John, I mean, I think we probably, as we're moving forward with the second half of this work plan, I think it will be totally necessary for us to work with some of the places that might have some data available to test out measures. One of the biggest issues with that is that we're talking about getting information from the providers that currently there's no way to get from the providers. They send us claims information, but as we discussed in the work group, there's no way to include any race and ethnicity information along with those claims. But that being said, we can definitely work with them as we're trying to come up with a more quantitative measure. On the other piece that you were talking about in terms of establishing a baseline, one of the things that we're currently pursuing now, and I'm not going to make any promises that it will be on the report that we issue in July, is trying to utilize some of our other data sources. There's another project that we've been working on related to kids where we had to actually collapse data from a number of different sources across OHA and DHS. And we were able to take race ethnicity data from some of those other sources and fill in a lot of the gaps that we currently have. And we may be able to do that for some of the CCO measures. The big issue, which will be great for us to be able to have more complete information to attach to the CCO measures if we're able to complete this project in time. And that'll give us some big picture views, but then we have to kind of keep on working to address how do we get that information on a person level back down to the CCOs, because there would be some data use agreements and things such as that we have to work through. So, I mean, we're trying to come up with a lot of different ways to fill in what are current gaps in the information that we have, including the real core piece, which you guys talked about earlier with the MMIS data. But all of them are kind of clunky, and they don't work real well in putting together active quality improvement strategies.
I do think, though, that sometimes when we have asked the CCOs to, when we have rolled these metrics out and there's pieces missing like that, that the CCOs have helped fill in those gaps. So I do think there is a benefit to say, hey, here's the gap in the system, and because I do think some of the CCOs are collecting this data, that this may be the way to help resolve the issue that, you know, the OHA is looking at here.
Carla, Brenda had something to say.
I just want to voice my total disappointment, if that's fair. I recognize the conversations around the complexity and the gathering of the information. I just sit here recognizing that we've been having this conversation for so long, and that if our systems cannot possibly adapt to even asking the questions at the delivery system level, using that information, then we will never make the kind of progress we're hoping for. I appreciate that the committee resolved to having a process measure, and I appreciate the fact that there's a work plan and that we're elevating the importance of the work plan. There's something that's happening for me, though, on the inside, which is why are we here now, and what lessons can we learn from ourselves so that we don't feel like we're going to be this far behind the 8 ball when we're having this conversation in 2019, 2020, 2021. You know, it feels like we've got this systemic issue that continues to be perpetuated, and we're just hitting it at the fringes. You know, so I appreciate your comments around this board holding some accountability and some responsibility for ensuring that progress is being made at a clip that is reasonable and not getting so caught in the complexities of everything that we're trying to create that that's what stalls us. So I wouldn't have felt right if I didn't sort of voice my disappointment with our progress to this point and encourage us to continue to keep it on our agenda so that we don't, you know, let complacency slip into the conversation.
Yes, thank you. I just want to say I appreciate your comment very much. And yes, that is think, an ongoing, for lack of a better word, clunker for many of us in this work. And I think we have an opportunity now that we have brought some things to the forefront, identified what some of the barriers are, and we can't turn back from that now. We need to keep moving forward.
And I think there's consensus in terms of, eye on the ball is getting the data correct. And I also I appreciate your comments on the unintended consequences, but I think with Brenda's point taken, I think the unintended consequences are hypothetical, and we know that there are consequences that are happening with respect to the disparities. As we speak, we just can't see them.
Well, and I think that I hear you, and also think that not all of them are hypothetical. Perhaps the
No, I was
example I
saying,
gave.
they're not hypothetical.
Oh, I thought you
They're
said
real.
they were hypothetical.
No,
Okay.
the unintended consequences are hypothetical and could be, they're probably out there, but there's real consequences today that
Yes.
aren't hypothetical,
Right.
that we can't see in the absence of data.
Right, and I also believe that the unintended consequences are not hypothetical, especially when, we're looking at a variety of the measures.
Mhm.
And there's another one, very specifically, that we used to be called unintended pregnancy. It's called something different now, I believe. But some of the research is showing us that what's happening in the clinical setting related to attempting to reach that metric, what's happening in the clinical setting potentially to diverse cultures of women, does have some real-time consequences
I think
as
you're
well.
speaking to the interventions and the questions
Yes,
around
yes.
if the data points
Yeah.
us to the wrong intervention potentially.
Thank
But
you.
I think the point of health disparities have been around forever. The data is there, infant mortality, zip code data,
Absolutely.
this conversation, there's nothing new.
Mhm.
And so the question that I keep feeling is like, so, yes, I'd love to see the work plan. Yes, I'd love to see sort of the progress measured out over time, so we're not revisiting this conversation next year or the year after. And I'd also like to propose that the board hold some accountability for outcome measures in 2021.
Absolutely.
Yeah, that we get to that, not just saying process measure next year, oh, we can't get to outcomes, we're gonna do process measure yet again.
Mhm.
And that we've built that foundation to aim toward that.
Absolutely, that's our goal.
Yeah.
That is absolutely our goal, and I also would add that current research is telling us, particularly by Dr. Kamara Jones, who does work around the social determinants of equity, not health, but equity, that if we don't focus on the strategies and interventions that are truly dismantling the system of oppression and racism that the system is built upon, that we could end up not getting to where we need to get the equal outcome measures, right? So I think that what I'm hearing and what I think our committee is really willing to do is how do those things interact, right? It's not an either or. Right now we have to make a choice that put us in an either or situation to some degree. But as we move forward, and this committee has more time, not just 4 months, but more time to look at all or as many of the impacting elements as possible. I think we don't dismiss the outcome piece. Absolutely, we do not. What we want to make sure is that this is all working in tandem. and moving forward.
Carla, this is David. I'm just looking at the time. Should we move on? We got a little bit behind with my comments and technical difficulties. Carla? Carla?
Well, Carla's waiting to come
Right.
back. I think this is a good conversation for us to hear. I mean, the equity was obviously prioritized, one of the 3 priority areas of the retreat. I don't think we got to the point of what exactly does that mean and what's the work plan for the board look like over the next year or two. And I think maybe we need to actually think about this as, well, what are some things the board can be doing and conversations the board can be doing to not just get us to a measure for 2020, but also be thinking about how do we actually lay the groundwork for where do we actually need to be as a state in order to really make a dent in equity and think about it in those terms. And maybe that's longer than a 1-year work plan, but maybe we can take that back and do a little bit of thinking on our end and bring something back to the board.
I'm sorry, I was on mute.
Okay.
I would say, thank you, Jeremy. I appreciate all the feedback, and this report looks like it's supposed to be informational. So as
as Leanne and John can see, we're very, very interested in the work of the group, and we look forward to hearing, continuing to get progress reports. So with that said, I think, John, you're talking about cost benchmark next steps.
I am, and I need to check and see if Stacy Schubert is also in the room.
She is.
I am, yeah.
Okay, the video runs a little bit behind the audio, so I'm still seeing Leanne sitting there at the table, so.
Well, I'm just taking my place.
Okay, and actually, as you guys heard earlier, I have changed roles, at least on an interim basis, and Stacy and I talked about this a little bit yesterday, and I'm gonna let her take the lead on going through this high-level roadmap that we've put together.
Yeah, thank you, John. So as you all remember, we met last month during your retreat and began talking with you about the cost growth benchmark. And you asked us to go back and put together a roadmap, and so that's what we've done here today. And it's really a conversation piece. We're asking for feedback and for you guys to fill in where you may need more detail or want to, pull back or dive in deeper over the next, let's see, it would be 6 meetings or 5 meetings, I guess, from today. We put the end point as July of this year because at that point we hope to actually know what's going to be put forth in legislation. And then that will help us to focus in a different way than we can right now, where it's a little bit more diffuse as we're figuring out where we're headed. But we ended up putting together a roadmap that really has 5 big buckets in it. Communicating effectively and transparently, and that's not just with you guys, but with entities that may be subject to the cost growth benchmark, those entities that may have an interest in the CAP, and the wider community. And I know, Jeremy, you've been having some discussions that would fall into this bucket, but what work do we need to do and to ensure that we're communicating effectively and transparently with everybody who could be engaged in this work. We also need to educate stakeholders internally and externally. Why is this work important? Why is it important now? Enable you all to also be spokespeople to explain why this work is important and why it's important now. And just engage as many people as possible in that. Also, we'll be starting to look at the data infrastructure and in particular trying to assess, again, not entirely knowing what will end up happening during legislative session, but trying to assess what data we currently have that could be used toward measuring the cost growth benchmark and what additional data we think we might need. And then defining the governance process. This is, probably going to be, we'll be defining the governance process in terms of not really naming who would be doing the work necessarily, but what roles and responsibilities are going to be engaged in the cost growth benchmark work. And specifically what role Oregon Health Policy Board will have, the committees, and potentially other government agencies, because there will be a lot of entities engaged in this work, probably 1 or maybe 2 that are actually accountable for doing the work, but not just those 2 doing everything. And then analyzing policy options. How do we actually want to implement this? What are potential adjunct pieces that are a little different maybe than what's happening right now in Massachusetts that we would like to pull into the work that we're doing? We've talked quite a bit about equity here, so how would that tie? One of the Senate Bill 419 task force's calls to action was really a higher degree of transparency. So what does that look like? You know, that's one of the policy options to consider. So those are the 5 buckets that we had identified. And I should probably back up and say we did have a very informative conversation, John and Lori and I, and Jeremy was part of it for a little bit, with Millbank, and they've done work with 2 other states that have been working on cost growth benchmark type work. I don't think they call it that in those 2 other states. And when we sat and talked about this work, what could be done in advance of legislation being in place, these were the buckets that we decided made the most sense. And so it was informed based on the work that she's been doing with other states as well. So anyway, I'll stop there and ask for feedback and additional details. That are
Yeah, just a little, taking a step back. So I mean, I think where the board was in January was voting to, 1, support the Senate Bill 419 task force recommendations, and 2, directing us to start thinking about some type of feasibility study. So I would sort of capture this as, you know, as Pat mentioned, we're kind of inching along. There's legislation, and we're trying to figure out how do we gear up, anticipating that legislation is gonna direct work our way. And so this is kind of broadly what we're capturing in the really feasibility work of how do we lay the groundwork between now and July. What the current legislation is drafted right now, it sets up a broad stakeholder group committee that would develop an implementation plan. Talking with the legislators, I think they're anticipating the policy board's got a role in that, so probably like a subcommittee of the policy board. But knowing that there will be the legislation, if it passes anything looking like it is right now, would basically create the public process for the actual kind of business plan for how do you launch, you know, how do you make the final decisions needed to design this and then launch it. So this is really, I think, what we're trying to identify as the pre-work to leading into that, so we can launch that public process, you know, as fast and quickly as possible. All that to say, we're very early in the legislative session, and who knows where any of this goes. But I'm meeting with the 2 sponsors of the bills on Thursday, and to fill them in with some feedback we had on the bill, and let them know that the policy board endorsed this recommendation and are ready to go. And we've also been, you know, I'll just say there's a growing national interest in this. I was at a conference on Friday with a number of states around things states are doing around costs. This just keeps rising to the top of what I can see as exciting folks. Delaware's governor just did an executive order basically directing the agency to create a cost benchmark program. Rhode Island's in the midst of creating one. New Mexico is in the process of launching one, and the poor folks in Massachusetts have now are spending more time, I think, advising other states than trying to actually run their program that's creating their own challenges. But there's growing momentum that this is a kind of critical component to where states can really try to leverage their their own tools to try to contain costs, and folks will be looking at Oregon as we move forward. But we've got some good resources we can pull from national experience of other states.
You did such a great job at the January retreat to inform our board around the issues, and I think from 419 we learned a lot. And I think at that time you also said that there's going to be a series of education for the board between now and, I'm assuming, July, to continue to do that pre-work that you're describing. Do you have a sense of exactly what those, I mean, this is a very, very big universe. So I'm wondering specifically, what are the components of board education that you think are going to be most critical for us to pay attention to?
Well, let Stacy dive in here, but I think it's kind of embedded in that. I don't think we've gotten there yet, but I think it's embedded in those first 2 bullets. Is really starting to think about, you know, using the data we already have. Is there some analysis we can do to start to tee up understanding, you know, what's going on with common trends? What do we really mean when we're talking about cost containment? And I think there's definitely some work we can do around, you know, both better tapping into our data and informing you all, and you know, creating some frankly public dialogue about what's going on in the healthcare system. The 419 group did some of that, and I think we can do more of it. So we haven't quite gotten to what that looks like, and Stacy, jump in if I'm way off track here. But I think trying to think about, you know, how do we you know, spend March through July helping get the board up to speed on just some common understanding of trends and what's going on out there, you know, what do we know from the data we have, and where do we have gaps?
So do you anticipate that, that there will be a section of our agenda each month dedicated to, in this roadmap?
I think that's a detail we got to work out with you, Chair, but I'm throwing that out there as I think that's something we can do.
Okay.
Or whatever,
Right.
whatever cadence makes sense. If it's not every month, you know, a couple of sessions between now and July, whatever, however we want to build it out.
So I just want to check in with the room. So we are scheduled for a break, but we have the legislative update. Do we want to go ahead with that and then take our break?
Carla.
Or do we want to take our break now?
Kirsten and John had a comment, hopefully, before we ended this discussion.
And just quick, you know, there is other work going on that's relevant. I mean, I think since our last session, Health Insight released their total cost of care report to the public. So, you know, we have, to me, a provocative report that identifies primary care groups using commercial data that have low cost and high quality, and primary care groups that have high cost and low quality. It's interesting to look at that list. It's online. Look at it right now.
Benchmark us.
Pardon?
To benchmark us.
Yeah, well, just to imagine, so what are we going to do with it?
Yes.
What have they done with it in Minnesota, in other states? Because as is usually the case, it's kind of surprising. The data never is what you actually think it's going to be. We have a lot of beliefs and biases, and so there's other stuff going on that would be nice to incorporate.
Just to move things along, because I know we're behind time. Kirsten, do you have a
Yeah, real
comment?
quick. I just want to make sure that, like, when I read the draft Senate bill, that I think is supposed to move this work along, it doesn't feel very tied to the Health Policy Board. So I want to make sure that, like, the work that we are investing as the Health Policy
Yeah.
Board is tied to the.
Yeah, that's what we'll be talking about with the co-chairs on Thursday. We provided some comments back to them around how that could better align with the policy board's work, and in my conversations with them, that's where they're anticipating the work land, although in a committee of some sort that's,
Yeah.
you know,
Yeah.
broad stakeholders. So I should have some more direction on Thursday, and certainly for some reason, it looks like things are going the wrong, a different direction than the policy board's involvement. Certainly, we don't want to waste your time, but my conversations with them so far, they've been, you know, excited to have the policy board be involved. I think they felt like this is why the policy board was created, was to have conversations like this. I'll let you know if that changes.
Back to you, Carla.
Okay, so do we want to take a break, or do we want to do the legislative and then take a break?
I think we had a little bit of a break while the phone was down.
Yeah, Holly's on, so we can
Holly.
just.
Okay. Ollie?
We don't hear you,
Holly?
Holly.
Is Holly there, or is Holly on the phone?
Holly's on the phone. I think she may be called into the participant line. Holly, if you're on the phone, please hang up and dial in.
So let me ask, do we have anybody signed up for public testimony?
We do not.
Nope.
Okay. All right. We want to wait maybe just a few minutes to see if Holly,
Maybe we will take a break.
Yeah, let's do the break.
We have a shorter break, just 5 minutes.
Seems like the votes are lining up for a break.
okay, let's take a break, 10 minutes at the most, okay?
All right.
Thanks, Carla.
Most everybody here, so we're ready to roll.
Okay, great.
Jeremy?
And I,
Go ahead, Holly.
okay, great. Just to let you know, Pat is also doing his best to get there in person. I think he's stuck on one of the bridges right now. All right, so this is the time for the OHA legislative update. I will just line out generally where we are. We have 21 bills for this legislative session from OHA, and there are some of those that are placeholders that we are still working on. You should have the list of those 21 bills in your packet of information. I can do a really quick rundown, and just anyone can feel free to stop me at any time with a question. So just running down the list, we have Senate Bill 22, which is to help us build out the standards for behavioral health homes. We have House Bill 2265, which is Health Policy and Analytics Housekeeping Bill. We have House Bill 2035, which extends the work of the Mental Health Advisory Group. SB 23 is a bill that we have been working on with the Hospital Association so that we can have a more robust data set for emergency department discharge data and to make sure that that source of data is reliable. We have a placeholder bill, HB 2266. Right now we are holding that. It has a relating to clause on healthcare that allows us, if we need a bill later in session, it gives us a lot of opportunity. Right now we don't have a specific purpose for it. House Bill 2267, we're holding as a place for the CCO 2.0 fixes that we've been talking about and know are coming. We don't have that finalized yet. Jeff, I believe, is in the room and can describe more to you where we're headed with that, as well as, of course, Jeremy. House Bill 2268 is a bill that we're preparing right now. That is looking at CCO financial regulation and transparency. That bill is well underway and being developed. It was introduced as a placeholder, and we should have some language to put in an amendment within the next week or so. House Bill 2269 is reserved for our Medicaid package, Medicaid funding package. Two of those components are moving in a separate bill that we'll be discussing in the legislature this week. House Bill 2036, I will just say 2036, 2037, 2038, and 2039 all relate to technical fixes for PEB-OEB that were recommendations to move forward this session. House Bill 2040 shifts the composition of the Traditional Health Worker Commission. I believe Leanne is in the room, and she could also help describe where we're headed for that. We have 3 bills for the state hospital, Senate Bill 24, 25, and 26. This is a big focus we hope to move on in the next couple of weeks, where we're really trying to make the forensic evaluation process more fair and efficient, and as well shift some of the incentives we currently have for sending people to the state hospital under the 370 provision or the aid and assist provision, and make sure that people who are being sent to the state hospital truly need hospital level of care, and otherwise the incentive is to treat them and restore them in their community. And then we have some public health bills. SB 27 is our safe drinking water fee restructuring and increase bill. That bill is moving along. We have an amendment and it's been moving that out of committee this week. We have SB 28, which raises fees for food, pool, and lodging. We are working closely with Orla on that, and we hopefully will be moving that this week. House Bill 2270 is one of the 4 components that we've been talking about to fund Medicaid. It houses all of the tobacco, raising the price of tobacco and vape products. SB 253 is a bill related to relinquishing your public health authority as a county. And SB 29 is our public health housekeeping bill. So that is a very long laundry list. I'm very happy to take any questions you may have or areas to which you want more information.
Questions for the group?
Jeremy, do you have any more description you want to give on the financial regulation and transparency or the CCO 2.0 fixes that we're planning to add?
Yeah, well, just a couple of, I guess, comments. One, we're really early in the process, although things are moving really fast. They got an early start this year, but we're still fairly early in the process. But some things are moving pretty quick, including work around the Medicaid budget. As Holly mentioned, there's sort of 2 separate vehicles. One's not listed on here. That will be up on Thursday. Pat and I will be testifying in both House Health Care as well as in the Ways and Means Human Services Subcommittee around components of the budget package on this Thursday. And there's Pat right there. On the CCO 2.0 front, we've really got there's really two separate bills. One that I think really more of the policy option pieces coming out of the board's report are in the for the number now are in one vehicle, one bill, and then the financial regulatory piece, which is what I made a comment on earlier today around creating more ability to have more apples to apples comparison, looking at NAIC, aligning with NAIC requirements, which are the commercial insurance reporting requirements, not necessarily all the insurance requirements. Those will be in a separate vehicle, so we've split those 2, but I think that's about it. Both of those are being drafted and we'll start floating them with stakeholders and getting feedback once we've got amendments to share.
Carla, John had a comment.
Yeah, I don't need any information today on it, but in the future, I'd love an update on what has happened to the bills that came out of the 4005 process, the transparency in the prescription drug supply chain. I was involved in that, and it was a very unique group, so I'm just interested eventually in what happened with the concepts and all that came out of that.
I assume OHA doesn't there's a whole bunch of housing bills that are moving forward that I find very interesting. I assume that's out of OHA's domain, though housing is healthcare.
Yeah.
I look forward to a day when OHA and Housing Authority and Education have a forum to come together to talk about bills that impact each other.
We do through the Children's Cabinet.
You do? Okay, fair.
May I ask who was just speaking
That was David.
about housing?
David Bensberg.
Thanks, David.
And John, I guess
So
on the
I
pharmacy
just
piece.
would like an update on the group of pharma bills that are moving through and being discussed in the legislature. That can be something we could come back to and discuss. And I also heard how we're working across state agencies in a coordinated effort on housing, which is happening. And we'd be happy to come back and update on that as well.
I think the short answer on the pharmacy pieces, they've all been introduced. I don't think they've started to be scheduled yet, but there's a whole slew of pharmacy-related bills out there.
The Chair Greenlick in House Health Care is hoping to discuss, he's trying to group bills thematically, so there will be a day to which we discuss all the pharma bills on the House side. And I'm not sure if that is the intention of Senator Monis Anderson as well, but that is how the House is planning to move those bills.
All right, if there's no further comments, Then we will hear from High Talk. So is Susan, Eric, and Amy in the room?
Sort of. Susan's very close.
Susan's close.
Here. But we don't need to wait for her, I don't.
Yeah, I think we're good.
Yeah. Get the high top leadership.
Whenever y'all's ready.
Great, well, thank you for having us here this morning. First introductions, I'm Eric Dulin, I'm the chair of High Talk and also work at Pacific Source Healthline.
Amy Henninger, I'm the vice chair of High Talk, and I work at Multnomah County Health Department.
And Susan Otter is figuratively right here, will be here momentarily. She works at an OHA and heads the Office of Health IT. So, kind of just a quick overview of what we want to cover today. I think there's some supplemental materials in your packet that have some of the detailed kind of more status updates. We won't go over that today. We'll really kind of focus a little bit first on some of the background and just a reminder on how our work connects to the overall health transformation work, talk a little bit about our strategy and goals, and then spend the bulk of the time really talking about some of the progress in 2018 and what's on our plans for 2019, and really looking for all of your input on those priorities for 19 if we need to make any adjustments to what's already planned. So hopefully people can jump right in and ask questions as we go through the materials. Make sure I'm getting the right slide here. It's kind of weird behind you. I think it's always an important reminder just to talk a little bit about how Health IT connects to our overall transformation efforts. When we look at the coordinated care work we're trying to do, having the right patient information is obviously critical to that, and having the ability to collect that information, share that information, and do the appropriate analysis is also an important aspect as we work towards that coordinated care model. And so, I just think it's also a long journey. This is probably one of the areas that's a little bit challenging as we build out that infrastructure. We'll talk a little bit more about that. I think that some of the work we've done this year kind of highlights some of those areas of challenge that we have ahead of us, and I think that ties well to some of the CCO 2.0 priorities as well. So we really look at HIT and kind of what are the core foundational pieces. It's actually relatively straightforward, even though it's a bit difficult to get there. So the first part of it is really about making sure we've got electronic health records that are available. One of the things that we will talk a little bit about in detail more later is that, particularly in the behavioral health world, that's probably a little bit more challenging than in other areas. We've made a lot of progress over the course of time with some of the federal funding on incentive programs for electronic medical records. And behavioral health really hasn't seen that benefit, and so there's a real leg there in what goes on there. But the electronic health record is one of the kind of key core elements or the foundational pieces that are critical to it. The second step is then how do you share that information and make it go between different organizations. And then once you have all that flowing and that data available, how do we do some analysis and look at some of the metrics that are available once we pull that all together. So that's sort of the core of what we're after and have been working on for a long time now. Sort of the next phase of that, sort of the more transformational phase of that, gets into some of the value-based payment, population health management kinds of capabilities. That's sort of once you have everything in place, then you can do some additional work in those areas. And so as we continue to build out the infrastructure, getting into those transformation items is really where we see things going. A couple of interesting points. I think that if you look across the state, there's wide variation in terms of where people are. There's some people with very sophisticated and well-utilized electronic medical records. They're at a point where they're starting to look at other things like social determinants of health and those kinds of things. And there's places where, it's kind of in place and people aren't using it. And then you go all the way to some of the behavioral health stuff I mentioned, where there's not even necessarily electronic medical records available yet. And so that disparity really creates challenges in how we share that information. And so part of our work with High Talk is really making sure that we're trying to understand that landscape and understand how we can help those areas that are lagging behind, as well as promote that advanced use and really keep that moving forward. Introduce yourself before we.
Sure. Hi, I'm Susan Otter. I'm the Director of Health IT for OHA, and I appreciate you hearing from us today. Apologize for being a little bit late. I decided to take the bus. It's about an hour and a half, so. From Hawthorne at 35th. Anyway.
Just as a reminder, High Talk was created by the legislature in 2009, and then by additional legislation in 2015, High Talk was moved under the purview of the Oregon Health Policy Board. I think you're probably well aware of your responsibilities related to High Talk, to really charter High Talk, help set our goals and priorities for the years, appoint members, and then approve our strategic plan. High Talk's responsibilities are to really survey and look at the landscape of HIT within the state of Oregon, as well as try and stay connected to what's going on at a federal level, as there's some federal legislation and policies that certainly impact what we are doing here in Oregon. We also do work to really come together with that overall HIT strategy for the state, and then help oversee the work that OHA is doing to implement that strategy. We also appreciate the recent approval of some additional members for High Talk that all of you did. We're looking forward. We actually have our first meeting this Thursday with that new membership. High Talk now has 15 people on it, and we meet every other month. So thanks for giving us that additional people with some changes in people moving in different roles. We were down on our numbers a little bit, so it's nice to get that full group back and really try to focus on some additions around behavioral health and dental and some diverse members. So I think we're looking forward to having that broader group of people come together. And this is kind of a reminder slide on what our overall vision and goals are for Health IT. I think that most of you have seen this before. Our strategic plan was presented to the Health Policy Board in the fall of 2017. That strategic plan really kind of targets the 2017 to 2020 timeframe. And just to kind of run through the goals, the top first goal is really about having the ability to share patient information across the care team. So that's sort of that, making sure that as people move between different providers, that information from what happened previously is available to them. The second goal is really to use that data to make system improvements, and how do we sort of take and move into the population health arena and look at that kind of in aggregate across everywhere. And then finally, really, how do we let the patients contribute and participate in that and be part of having that health information available. As I said before, a lot of our work is really focused kind of in that goal one area. You sort of have to get everything flowing before you can start to share it and make it available to patients. I know that there's a lot of interest in sort of that consumer aspect of it. We really need to do a lot of that base kind of infrastructure work before we're really ready to do all that sharing and make it available to consumers. So with that, I'm going to turn it over to Susan, who's going to talk a little bit more about some of our priorities and the work that's been done in 2015.
Great. Thanks, Eric. So our strategic plan seeks to support the health system transformation priorities that the Health Policy Board has set forward in the Action Plan for Health Refresh that the Governor has set forth in her priorities for CCO 2.0, and to reflect the values of OHA, including accountability and transparency. So this slide shows you kind of a crosswalk of the priorities, the policy priorities from those areas, and the HIT strategic plan focus areas in our 2017 to 2020 strategic plan. So you can see we're focused on spreading health information exchange and supporting EHR adoption, which Eric has talked quite a bit about, supporting high-value data sources. So that includes things like public health registries. The Prescription Drug Monitoring Program is one I'll talk a little bit more about that we've worked on. And also looking into social determinants of health and adding social determinants of health data into the sort of care coordination sphere. And that's an area that we'll talk more about, that we're just starting to explore with High Talk in 2019 and want to get your feedback on. We want to leverage health IT to promote health equity, and we are focused on implementing core health IT infrastructure. That includes the Emergency Department Information Exchange, which has been live since 2015. I'll mention a little bit more later. Our statewide provider directory, which is launching later this year, and our clinical quality metrics registry, which just launched this last month. We also are looking to support value-based payment with health IT efforts. A lot of our work around that has been around the clinical quality metrics registry, having an efficient way to collect those metrics from providers and make them available to CCOs, to OHA, to Medicare, and to other payers. As well as our policy priorities for CCO 2.0 include a policy area around health IT that CCOs need for their value-based payment. The fourth area here is supporting shared governance for long-term sustainability and alignment. And I realize I need my glasses. Sorry. So the work we've been doing on shared governance, we'll talk a little bit more about our public-private partnership in Oregon for health IT called the HIT Commons. So we're really excited about that work. Spreading patient access to data and reporting on OHA's progress and the HIT environment. So I just wanted to give you a sense of how the work we're doing, we really try and make sure we're aligning with the priorities and vision that you all have. And that's our question for you today as we look at our 2019 priorities. We want to make sure that we're in alignment with what you all are doing. Any questions on this piece?
I've got one, if I could.
Yeah.
This is Pat Allen. When we talk about information related to either social determinants or equity, does that include looking at ways to make up for our lack of race ethnicity data on the enrollment side?
We would love to be able to tap into race ethnicity data that's in electronic health records to the extent that it is, but we don't have systems right now to collect the data properly. So that's something that we'd love to explore further.
We had about, earlier when Leanne was here, about a 20-minute conversation about creating that data, or improving that data collection system, as goal number one for achieving health equity.
Yeah, I'm sorry I missed that conversation. I'm maybe around to the place where improving that system is likely to be less effective than finding alternative sources for the same data.
I think what we summarize that conversation is, I think we charged Leanne with a work plan to say, how do we don't have data on race, ethnicity, and disability, then we haven't even started to attack the issue of health equity.
Right.
And we've been asked, and that should be having some type of data, complete data, reliable data,
right.
Should be job one.
Can you say more about that, Pat, about your comment about that it may be easier to look at other sources than to fix?
Well, just I've been trying to engage a little bit with this for, 6 months, and you probably know we have about a 50% refusal rate to provide the data from those who are signing up, and we have a federal prohibition on requiring an answer to that question before being able to move on with enrollment. And there is certainly some notion that an enrollment specialist working with someone can be better trained to not take no for an answer, at least initially. I'm dubious that we can, turn that refusal rate from 50% to 5%, right? And so it makes me wonder if we shouldn't be looking at alternative ways to try to get the same thing. Oversampling in the census to figure out, what's the ethnicity from a census standpoint of people in the Oregon health records, if that, to the extent that data exists. Something through CCOs, I'm not sure what, but that's kind of what I'd like us to, as an agency, to puzzle through is rather than just kind of get dialed into, we got to figure out how to get that 50% refusal rate down. Could we get better results by doing something different that might not be as daunting as that?
I also only heard part of that earlier discussion. I wish I was here for the whole thing, but I know that just from a health plan and CCO perspective, that data is also difficult to gather either from other sources. So it is a challenge to figure out how to try and source good data for that.
Yeah, but to your point, you're exactly right. At a 50%, we have no idea. We don't know what we're doing.
So So I wanted to talk about some of the progress we made in 2018 in High Talk. It was a busy year for High Talk, particularly with CCO 2.0, not a surprise to any of you, I'm sure. We looked at our meeting hours and calculated about how many hours we had of substantive discussion. About a quarter of them were spent on CCO 2.0 presentations and input sessions this year. So what was great about that was it killed two birds with one stone for High Talk. It enabled High Talk to get up to speed on policies around value-based payment priorities, social determinants of health, improving the behavioral health system, and to really think about how our health IT policies for CCO 2.0 supported those other areas. So that was a great part of 2018. High Talk also convened 2 ad hoc stakeholder listening sessions on our HIT policy priorities, and we had great attendance across a wide diversity of members, which was great. We also initiated some strategy work around behavioral health and health information exchange, our approach we're calling Network of Networks. We expect to continue both of those in 2019, so we'll talk more about that later. And then we received reports on Oregon's health IT efforts and reviewed new data, heard from stakeholders on the evolving health information exchange landscape, spent some time reviewing proposed federal policies around a trusted exchange framework, and finally, as Eric mentioned, we filled the 6 vacancies with you all in December. I wanted to highlight one area of progress before we move on to our 2019 priorities. So when we came to you in September of 2017 with our strategic plan, we had 2 new areas in that strategic plan. One was around our public-private partnership, the HIT Commons, and the other was around our health information exchange strategy of Network of Networks. The HIT Commons is a public-private partnership meant to accelerate and advance statewide health IT efforts. It's co-sponsored by OHA and the Oregon Health Leadership Council, and jointly funded by OHA, CCOs, participating health plans, and hospitals. So we have a great funding model where we're able to bring 90% federal matching funds and some state funds for the Medicaid share, and our hospitals and commercial health plans are bringing sharing the costs for the rest of the through assessments. The Emergency Department Information Exchange was foundational work that started in 2015, and we took that public-private governance model and expanded it, launching in January of 2018. So we launched the governance board in January 2018. We've had a crawl, walk, run strategy. So we started very small in terms of the administration of that. The Oregon Health Leadership Council staff really have staffed that work. Towards the end of 2018, we moved into more of our walk phase, or late crawl maybe, and they formed a single entity LLC. So now HIT Commons is its own organization as a single member with OHLC as the member. They're working to hire a couple staff, so we're sort of starting really small, but we're getting good traction. We continue to see the spread of EDDI and pre-managed statewide. EDDI connects all Oregon hospitals, as well as Washington hospitals and some other neighboring states, with hospital event notifications. So I could do a whole presentation on EDDI, and we decided not to focus on that today, but I just want to mention briefly what it is. So we bring in hospital event data out of the electronic health records for all hospitals. That includes emergency department and hospital admits and discharges. That information is then available real time back to the emergency department. When they register a patient, it checks the system. If they've been a high utilizer of services, it sends back a notification saying, hey, this person has been seen in all of these different emergency rooms on these dates for these reasons. It also includes care guidelines that users can input, saying if this person shows up in the emergency room, here's what you need to know about their care. And we're very excited we've been able to connect prescription drug monitoring program data in as well. So now EDDI alerts for 27 of our EDs include opioid prescription information for individuals that have triggered a particular threshold of opioid use. So pre-manage is this tool that's has the same data as Eddie, but it's used by the CCOs, the clinics, the health plans. We're seeing broad use of that across all CCOs now. Most of our major commercial health plans in Oregon. We have about 200 primary care clinics. We have dental, we have behavioral health. We have now 4 tribal clinics on pre-manage. And we're really excited about having one tool that all of the different care team members are using to look at that patient that's been high utilizing or is at risk for hospitalization. So those care team members are entering care guidelines that then again can be seen by other members. They can enter care histories and other things as well. So this has been a really exciting tool that's been in place starting in 2015, and we just continue to see spread of that. I'd like to talk a little bit about the second initiative, the Prescription Drug Monitoring Program Integration Initiative. It's a good example of partnership and the role that Health IT plays in integrating into a provider's workflow and the value of that. Before I do that, any questions about Eddie or pre-manage?
Is Eddie mandatory or voluntary?
Eddie is voluntary. The exciting thing about, the interesting thing about the Health IT Commons and the way this public-private partnership started is we incentivized hospitals to participate, to make the decision to participate, because without statewide hospital data, the system was going to be less useful. So we were able to put grant money into the first year. If the Oregon Health Leadership Council got the agreement of 75% of the hospitals to participate, they were able to, the great thing about the Health Leadership Council in this situation is they have relationships and influence over leadership in many of our health systems. And we're able to even use peer pressure to get all of the health system and hospital leadership to agree to participate. Nobody wanted to be that one that didn't. And they were able to get 100% commitment early on in 2015. So we have other states that are really jealous of what we have in Oregon and have asked us what was the secret sauce. And some of it is that, Oregon Health Leadership Council sort of peer pressure component. And then the CCOs and health plans, it's voluntary for them to use pre-manage. However, we are requiring as part of our CCO 2.0 policies that the next round of CCOs participate. Yeah.
Can you speak to why 27 emergency departments are included in the opioid?
Yeah, sure. So I'm going to talk a little bit more about the PDMP initiative. The Eddie alerts can come into a hospital system either integrated into the electronic health record or to a secure fax or printer. And with the opioid information from the PDMP, that is very strict controls over who receives it. And so it's only available for the hospitals that have integrated their Eddie alerts into their electronic health record. About a little more than half have, but we still have some that are smaller hospitals often, not all that are small, that are getting it to a secure printer. We have some federal or some state grant funds for rural hospitals that they can use to help support integration costs, and that's available through the Hospital Association's Rural Foundation. So we're really trying to get those last other hospitals on. So, and then of the hospitals that have it integrated, not all have gotten the paperwork signed. It's really the barrier ends up being the legal agreements, much more so than the, just in terms of the time it takes to get through those, more so than the technology.
Has the HIT Commons set forward its 2019-2020 work plan, or are there specific areas of focus that we should be knowing about?
Yeah, the HIT Commons has particular areas of focus both for its Eddie pre-managed work and for its PDMP integration work. In terms of Eddie, they are supporting learning collaboratives in communities. They found that the most effective way to make sure folks are using this tool and doing it in a coordinated way is to engage locally. So there are regional learning collaboratives that they're continuing to support and expand. So that's one area. That's one of the main areas.
So beyond Eddie and pre-manage and the PDMP, are there initiatives that the collaborative sees itself kind of dipping into the future?
Yeah, thanks for that. I forgot to mention. So one of the other things that the Commons did this year was develop a proposal review process. We've gone through that process. We've requested that the HIT Commons support the Oregon Provider Directory when we roll that out later this year. We would continue to own that program, but we would look to them to help what we call adoption and spread of that program. And they've agreed to help us with a use case test. So that's definitely a piece that they're taking one step into that. And then there's some interest in our network of networks, so spreading health information exchange statewide, and where the HIT Commons might take another a piece of that work. So those are the two things that they haven't approved anything on the network of networks statewide HIE, but that's something that we've teed up for their consideration this year.
I think it's part of their kind of crawl, walk, run strategy. They've really tried to not set such a big, huge agenda and really be very selective about picking only a couple of things and not saying, here's a whole bunch of stuff we can work on. So I think that's part of why you sort of see this focus with Eddie and pre-managed work and a couple of things kind of on the horizon, but not a lot more. I would expect we would probably see that develop a little further during the next year or two as that gets next.
I was just gonna say, I think that the HIT Commons, it's relatively new, and I think a pretty exciting venture. And kudos to Susan and High Talk for helping get it off the ground. I think what it really does for we have federal dollars we can bring to the table, but we have no shortage of vendors who would like to come to us and tell us that we should buy X, Y, or Z. And I think what this really does is allow us to have a forum with with our stakeholders to decide when's the right time to pick off which next IT initiative and make sure there's buy-in as opposed to just being told by the state. And so I think they're trying to get it off the ground, make sure it's successful at the right pace. But I think it's going to be a huge tool long term for the state.
And I should also say the idea of a public-private partnership has been in our strategic plan since 2010. And so this is something we at High Talk in the state have been excited about. We see this HIT Commons as a path to our long-term sustainability for statewide health IT. And so that buy-in and going slow enough so that folks are all really realizing that value and bought in is a component of sustainability.
And you had to set up the LLC from a governance perspective. You couldn't have the relationship directly with private hospitals and systems.
Can you say that question?
Oh, you said you set up an LLC for Commons?
The Oregon Health Leadership Council did, yes.
Yeah.
It was more of a decision on the Health Leadership Council's side that it was starting to venture into managing IT projects that was beyond kind of their core competency, and so they decided to set it up as a separate LLC.
And beyond the scope of OHA.
So it's a public-private partnership. So we have a specific part of the governance board. We have a role on the governance board, and we are contributing a considerable amount of the funding because we contribute the Medicaid share, and Medicaid can take up a considerable amount of the share.
Just generically, public-private partnerships often work best where the private side is the structure and the public side is funding.
Okay.
Certainly helps for some of the procurement and acceleration of some of those processes, contracting and things like that.
Where we can still maintain strong accountability through.
Okay. So I wanted to highlight some of the exciting work with the HIT Commons and the Prescription Drug Monitoring Program Integration Initiative, and then we'll turn to our 2019 priorities. So, oh gosh, this is you. Yes.
So one of the initiatives from the HIT Commons is around the integration of the prescription drug monitoring program. So this program helps providers make decisions by letting providers or authorized delegated users see controlled drug histories. And part of the problem historically is that you have to go through a separate website. So when I'm in my electronic health record, I know I should be looking at the history, but I have to log out, get onto a separate website, get out my phone, look for my password for the PDMP, log on, then search for the client. And so it's a really cumbersome process. And so what this integration has done is allowed the users to get that information right within their workflow, which is huge because you're not going to use it if it's not easy to use. So currently we have more than 3,700 prescribers and 200 pharmacists integrated as of today, and there are 12,000 prescribers in the queue for 2019, and I'm hoping I'm one of those. If you look at, this is the PDMP registration, you'll see a huge bump from 2017 to 2018. A lot of that has been around a legislative mandate.
Oh, yeah, for some reason,
the light line.
The light line on the very top.
Yeah.
Yes, or just, you can't see it on the.
We've got it here.
Okay. So as of 2018, all prescribers were at 83%, and then the top 2,000 prescribers are up at 96% of just being registered. That doesn't mean that people are actually using the system. And then if you look at this one, the HIV Commons success metric was really looking at a 30% increase in the number of queries, and that has been met. So the circle line at the bottom, which you can see in your packet, are the ones that were integrated, and so you can see that went from 0 because there was no integration up to 30,000. There's also been a huge steep increase in the EDI integration of seeing what those prescriptions are for those high utilizing patients. And then the queries for through the web portal has increased some, but not as steeply as the other ones.
Can I? Yeah. I can't resist. Is the VA included?
You know, that's a great question.
Because when I was at the VA, it just drove us nuts to figure out what was going on the private side with veterans.
You know, I don't recall the answer to that question. I know it's complicated and that they're not required to include their prescriptions, and I don't want to misstep if I remember it incorrectly. So let us get back to you with that. One thing I wanted to mention is there was a survey of prescribers for the PDMP, and the top 2 barriers to PDMP use were time. 72% said I don't use it because I don't have time to go in into the web portal and click everything. And the second top barrier was forgotten password. 59% said I don't use it sometimes because I forgot my password. So integrating into the workflow, having a button in your electronic health record when you're looking at a particular patient to be able to push and get their PDMP record reduces provider burden, addresses those barriers, and I think helps with some of our, in a small way with provider burnout when we can help them make sure that they're getting the data that they need.
And then there's better care.
And then there's better care, thank you. Yeah, and so the whole point of the PDMP is to ensure that prescribers have the information they need to make the right decisions.
Any other questions on any of the kind of 2018 work before we talk about 2019 priorities, or any other questions? It's been a good discussion so far. Great. We'll jump into our 2019 priorities. We're going to go through, I think, all but one of these in a little bit more detail, and then we'll come back to this slide at the end, so I won't spend a lot of time going over it. I think we'll talk about all of these except for the one on dashboards and milestones, and we'll cover that at the very end. So we will just jump into the 2019 priorities with Amy talking about the social determinants of health.
So I think one of the important things, this is a new area of focus for HighTop for 2019. We touched on it a little bit in 2018. And we've had some initial discussions. one of the areas where it's critical is really to, number one, be able to capture and put the data in some kind of electronic format. And then once that data is there, we can help coordinate care between providers and social determinants of health organizations, with ideally the idea being that we can actually have some kind of health information exchange between those organizations. The HIT tools are also useful for managing the referrals, for addressing the social determinants of health, and then eventually using that data for risk modeling and population management. For 2019, HITALK is going to be having a panel discussion with organizations piloting the HIT for that social determinants of health work, really to help us understand what are the current efforts, and then what our potential role is in the future. HITALK is considering the recommendations for future work, possibly through a work group, and it may also be included in a strategic plan update for 2019.
Do you have a candidate list of social determinants of health that you are considering collecting?
So right now, we're not considering adding a new system to collect data. What we're looking at are, what are the assessments that are currently being used? There are several different ones we've heard of, some of which are integrated into the electronic health records, which is really exciting. Being able to crosswalk the data in those assessments to codes or structured data, including something called Z codes, that allows folks to take data in and transfer it to another system, and it could be interpreted that, you could actually collect it and interpret it and analyze it. So what we're looking at is what's already happening out there. Is there a need to come together around aligning code sets or spreading best practices for specific tools? So we're really just starting to get the lay of the land. We approach developing a new data system very carefully. It takes us a long time to do anything like that. So
I think there's a lot of risk of potential confusion in this space, and as each entity, and several of them that are ongoing now, are collecting have different definitions, and I'm wondering if HITALK has a role in creating standard definitions for this particular space.
we could. I think one of the other things that's challenging around this area is, in a situation like that, is it a technology question, or is it a clinical innovation, or question that would go, or an analytics question that would go to a different organization within OHA? And so one of the things we're doing in OHA is we have a social determinants of health work group across staff, so that we make sure that we don't take on something if it really needs to be in a different office and that we're coordinating. So so it's possible that code sets, and aligning around code definitions was something that was important, that might fall to HITALK or HIT is something that we need to work on. It might land somewhere else.
Yeah, as a service provider, I would just plead that we find the standards sooner in this process than later. It's quite confusing work,
The other concern that has been brought up, is around a trust framework for sharing information. So social determinants of health providers are typically not HIPAA-covered entities. And so what is the consent needed to be able to capture this information and share something with a physical health provider for that patient? That's something we've also been asked to take seriously and get thinking about sooner rather than later. So those are two things that have come up so far.
So, even if you're not collecting new data, just to survey what is out there, what should be used, seems like an enormously complex task.
Yeah.
I look forward to following closely.
The challenge, I think, and we've heard this, we met with one organization recently that is building out kind of a connection for CCOs for referrals, and they really emphasize, they've done work in a bunch of states, and they really emphasize this is community by community, because every community has a different set of resources and different referral patterns, and so you kind of have to build this on the ground if you want to get it right and make sure, but that just makes it all the more all the more complicated.
And when we have overlapping CCOs and communities that are approaching it differently, that makes it even that much more complicated again. Yeah.
But if you could get housing, criminal justice, ACEs, the SNAP, there's a lot out there.
There's a lot out there.
Yeah, I kind of work on the fringes of this area a bit in Open Notes, and the Office of Civil Rights has a request out for comments on HIPAA, and the privacy issues here are really daunting. And you could imagine someone might say, "Well, this ED system, I don't want I don't want a hospital emergency room to know anything about me." What is the individual's privacy rights versus the system's rights to interoperability and all? So these are very, very tricky issues. And I hope Office of Civil Rights modernizes HIPAA, because some of the issues you mentioned here, you have somebody struggling in the housing system, or the school. That one of the reasons for the difficulties with the schools is HIPAA. And the concerns about the schools giving health systems information on it, vice versa. So it's really challenging.
I think one additional role also is for clients to actually utilize something through information technology to access resources, right? So if you had community level resources that someone, as we get to the next slide around exploring patient engagement, in Chicago, they have they go through their patient portal into their electronic health record, and then can link to resources that are constantly updated electronically instead of going to the social worker's office and pulling the purple binder off the shelf, which is pretty smart.
I think our challenge in this area will be, where do we focus once we have more of the lay of the land? I think that's so new. There's so many exciting things happening. We want to be judicious about what we focus on so that we're adding value and getting at things that are urgent. So.
ACEs and housing.
ACEs and housing, that's your
Okay. That's my note, yeah.
Okay. So in 2019, High Talk proposes to dive more deeply into the patient experience with health information technology. There's definitely huge value that HIT can bring patients to improve their health. There's both improving patient engagement with the care team through the portal that we talked about, things like scheduling, direct messaging with your patient care team. It also helps patients collect and track their own health information, so being able to see notes, labs, x-rays, remind a patient reminding themselves of something they wanted to ask about from a prior visit. High Talk's work so far has included supporting Open Notes, which is where providers configure their portal so that the patients can actually see the full text of the note from the visit. We've explored HIT for patient engagement as part of CCO 2.0, and then we've also increased on High Talk the consumer representation. For 2019 High Talk, we're having a panel discussion with multiple organizations to better understand current efforts and High Talk's possible role.
So I have a bit of a conflict here. I work for Open Notes. But, we see this huge opportunity that EMRs and HIT is going to become patient-focused rather than billing-focused. But the rules, I think, need to be looked at. there's restrictions on sharing screenshots of existing HIT products. You can understand that when it's about building. But when it's about patients and which look on a screen works best, and communicating to patients, you're going to have to communicate more broadly. Measuring, of course, how well this is working for patients creates a whole metric issue, which we're beginning to wade into, and not surprisingly finding, disappointing results. It's one thing to turn open notes on. It's another thing for patients to actually be able to find their notes. And of course, there's some vendors who go, we don't care about notes. We're not going to spend any time or money on that. At what point do they, become accountable? So I think I'd urge you, as you look at your engagement process, I think the rules should be a bit different for vendors, especially. And they're not used to that world. Their customers have been health systems focused on billing. Now some of their customers are going to be focused on patients. So my 2 cents.
Thanks. And I think we'll have more buy-in also in the future as someone told me recently, patients are your cheapest employee, right? And so as patients are putting in their own information and the system can ingest that information, that's free labor and it's more accurate data. So I think that will be helpful.
Okay. The third area that we're focusing on in 2019 is wrapping up some of our behavioral health IT work. We undertook a SCAN survey of behavioral health agencies and also follow-up interviews to get more in-depth information. Those results came to HITALK, and HITALK requested that we convene a behavioral health work group of experts to prioritize what do we do with this, what do we need to do moving forward. So that work group brought its recommendations to HITALK in 2018. I'll mention those in a minute. And then HITALK expects to convene a behavioral health work group to stage and help advise OHA on the feasibility of some of those recommendations and develop a work plan that will come back to HITALK. At which point HITALK would move into its oversight role and really overseeing the work under that and getting reports on that, on those strategies. So it's possible if we do a 2019 strategic plan update that would come back to this body, we may want to include some further detail about the behavioral health strategies in that work plan. We also may hold that strategic plan update till next year if we don't have enough substantive things. So I just wanted to share a few quick results from our behavioral health scan. We surveyed all licensed behavioral health agencies, so agencies that have a licensed behavioral health program in Oregon. This doesn't include your, mental health counselors that aren't licensed for through the state or what have you. So it's licensed behavioral health agencies. We had about a half 50% response rate or close to that. We found that 76% of agencies had some kind of electronic health record. Many of them were not using that for all their work, however. Many of them also had paper processes. So we called them partially implemented. These weren't necessarily certified electronic health records that meet federal standards for interoperability and other functionality. Of those that have an electronic health record, they are challenged by financial costs and the inability to exchange information. Of those who don't have an electronic health record, they were mostly smaller organizations, and their barriers came down to mostly resources. We also asked about health information exchange and found that if the way this slide is organized, the more paper processes or less electronic are on the bottom, and the more exchange through electronic mechanisms are at the top. The orange and yellow are agencies that use that method some or most of the time, and the blue is none of the time. So you can see if you just blur your eyes, that most people are using non-electronic methods to exchange information. And most are not using any real substantive electronic methods like pre-manage, a health information exchange, Epic Care Everywhere, or a shared electronic health record. So we do have some using direct secure messaging, which is a HIPAA compliant secure email. And we have some using secure email, but many are fax, e-fax, and even paper. So this is just a snapshot of some of what we're talking about with that digital divide, that few of our licensed behavioral health agencies have robust electronic means to exchange information.
I think the other interesting thing in the behavioral health world to highlight is that, you know, we've talked a lot about the not all of them are on electronic health records. Even those that are, they're generally, you know, there's 30, 40, 50 different systems in that environment. There's not an Epic that everybody's on, you know. So if you look at on the medical side, we have such a huge presence of Epic in the state. People could use Care Everywhere and start to share stuff pretty readily. So even in the behavioral health world, even where there is adoption, it's not necessarily into systems that integrate well or can talk to each other very well, which further complicates the sharing of information.
And is that a financial barrier for Epic implementation, mostly?
Part of the challenge is that behavioral health, the needs a behavioral health agency has for electronic health records don't fit well in the medical EHRs because they're looking at, you know, longer term care planning, they're looking at, you know, progress towards meeting goals, some of those kinds of charting that they're doing in their for behavioral health.
So it doesn't fit with an Epic?
So some are using Epic, but not well. That's, yeah, so they're still using paper processes, or we even have organizations that have half their, like they might have their mental health on an electronic health record and their substance use treatment on paper or on even a separate electronic health record.
Seems like an incredible business opportunity for Epic. It's not just Oregon.
Again, it's more complicated. I mean, I've been surprised at the concerns that the mental health folks have about the physical health folks seeing their records. When Epic does do this, or the bigger vendors do this, they have these break the glass processes. So that if as a primary care doctor, I want to see a psychiatrist note, I have to break the glass. I can look at the note, but there's a report going to the psychiatrist and to other people. Santa's doing something he shouldn't be doing. He may be doing something he shouldn't be doing. So again, it gets at these privacy issues that some mental health patients don't want their primary care doctor.
It's almost as if some things we do to protect against the stigma of mental health create stigma
Yes.
of mental health.
That's right.
Yes, and you know, I think it's a benefit risk. At some point, the benefits are greater, but it's very difficult to calm the people who are worried about the risks, and they're hypothetical. A lot of these are, has that ever happened? I mean, I go to organizations now commonly and I ask them, the medical records folks, so there's a process here where when somebody asks for their record and they have mental health records, you have to check with the mental health clinician if they want to give them the record or a summary. How often do they say summary? The answer so far has been never. So it's there for a hypothetical, but it's never, or very rarely appears to be used.
We used to have the same restriction around HIV information. And it was a major barrier to continuity of care. And it was related to the stigma of HIV. Once HIV becomes less stigmatized, the information flows easier. So it is really addressing the stigma of mental illness.
This issue around privacy concerns came up in our top barriers. So if you group these together, the top barriers are around resources and privacy. So financial cost is number one. This is barriers to sharing electronic health information. Two is privacy and security. Technical resources, so again, resources, concerns over liability, back to privacy. Technical infrastructure is not enabled, so that's technical regulations, et cetera. So a lot of what we heard in our survey and in our interviews, and we hear all the time from stakeholders, is the restrictions around sharing substance use treatment information under 42 CFR Part 2 that require proactive consent are confusing. And so organizations have, are unclear how to navigate those regulations. Even when they are clear about them, it's difficult to manage consents and all of that. A lot of times mental health and substance use information is combined, and so who the requirements apply to can be challenging. One of the things that we're excited to do is we're working on a provider toolkit around 42 CFR Part 2. So a model consent form, an FAQ, and some of that working with our behavioral health policy unit and OHA. It's been underway for quite a while. We're getting very close to finally releasing a draft for stakeholder review. The top recommendations of the behavioral health work group, after looking at our scan data and our interviews, was to support behavioral health agencies without an EHR or an insufficient one to get one. So our work group was concerned about the digital divide and also concerned about maintaining diversity in the behavioral health provider community so that you have small organizations that are really effective working with specific populations. Those need to be supported with supports around electronic health records as well as the larger organizations. Secondly, to continue our existing work on health information exchange, we've prioritized behavioral health agencies with things like pre-manage, and they're very excited to have those opportunities to see information across providers and get hospital event information, for example. And there's recommendations around bolstering with additional strategies. Behavioral health agencies and providers want a better understanding of the health. What do I get with my electronic health record? What should I expect? What's out there? What are the options around health information exchange? So a better understanding of the landscape as well as what tools are being used in Oregon to help agencies navigate this. And then fourth is modernizing state reporting systems to allow for improved interoperability for behavioral health providers, getting data back. Some work is underway in some of these areas, including our state reporting systems. But behavioral health agencies are subject to significant reporting requirements that need to come out of their electronic or clinical systems. And they talked a lot about the challenges of navigating with their vendors around that reporting. So our proposal is to continue the work with the behavioral health work group, have them help work plan or roadmap for some of the specific approaches under these 4 recommendations, working with OHA staff on feasibility, and then kicking off some additional work. Anything else on behavioral health before we move to our next area? Okay. The last one we wanted to cover before we review our talk about dashboards and review our priorities is continuing the work around statewide health information exchange and our direction around a network of networks. So our goal is that we have a minimum set of data available wherever patients receive care or services across the state. We have many different health information exchange efforts going on, which we call networks. So pre-manage and EDDI is one. We have regional health information exchanges. We have Epic to Epic and care quality across different vendors. So we want to build on the existing health information exchange investments and connect and coordinate across networks, as well as fill gaps if there are gaps for folks that don't have access to health information exchange. So this work includes coordinating stakeholders to develop the necessary framework, working on interoperability, ensuring privacy and security, practices are in place, and considering neutral issue resolution. We began the work on Network of Networks in 2018 with a panel at our April 2018 meeting. High Talk chartered a group, our technical definitions group completed its work in fall of 2018. Their first recommendation was don't call it a network of networks. So this title may be changing as we get into this work. Their point was that networks really exchange information, and coordinating across networks is itself maybe not a network. That may be coordination efforts, that may be policies, that may look like something that's not itself a hub.
So it's not electronic?
That's right. So what
Okay.
we're doing is identifying, given all of the health information exchange efforts we have in Oregon, how do we best connect and coordinate across them? And the answer may be they're already connecting to each other, so we need to provide a convening role and the right policies.
I agree with it. I was confused because I thought you were, this is electronic when you say network and network.
Right, exactly. So we may be changing the name, we haven't officially changed it yet. The overarching goal is statewide health information exchange. How do we make sure that we're achieving that? The other part of the recommendations that HITAC and our definitions group made was to focus on use cases, so high value use cases. Don't bite off the whole apple. Look at where's the greatest opportunity and focus on advancing that. So an example of a use case would be closed loop referrals across providers, so they know when a referral's been received and a service has been given. That impacts social determinants of health as well. Another use case would be complex care coordination or those sorts of things. So anyway, so more to come. I think some of the work will be identifying that use case and then drilling down into our specific strategies. So we plan to continue this important work in 2019 and identify that our next projects and partner ideally with HIT Commons around how they can help advance this work.
So this is the 2019 priorities. We talked about the top 4 bullets that I mentioned earlier. We are going to do some work on a dashboard that has sort of the core indicators of are we making progress, are we making progress in the right places, or do we need to adjust course? So there'll be some focus on that. We will also evaluate if we want to do an update to the strategic plan during 2019. As I mentioned at the beginning, sort of focused that on 2017 to 20, but there may be an opportunity to do some updates if we want to incorporate some more of the social determinative health work, for example, as we learn more about that. So we'll evaluate that during the upcoming year as well. But I really wanted to get your feedback about, does this look like the right set of priorities based on what your goals are, and are we on the right track here? So if you guys should have any comments or thoughts.
Question around oral health system integration or interoperability and whether or not that's been on HITAC's sort of radar, and if so, to what extent?
So oral health is definitely a part of our scope. It's a key component to the statewide health information exchange. So the network of networks is really looking at connecting across physical, behavioral, and oral health in particular, and then we're exploring the social determinants piece. We've thought about, do we need to do, like we did at the Behavioral Health Work Group, do we need to do an oral health scan and convene that group as well? And we have not committed to that yet. Oral health providers have been able to participate in federal incentives around electronic health record adoption, where behavioral health providers have not. So it was really, behavioral health was really a much more unknown area. But I'd love your thoughts on oral health.
Yeah, I mean, I'm an advocate, so I would love to see that arrive, I think, in a more explicit way on the work plan personally.
We do have oral representation on HITAC, oral health representation. Okay.
And I'm also curious about a more active verb choice for exploratory work and social determinants of health. If there's something a little bit more guiding oriented, or, I'm looking for the bounds and the rails around how big this issue is. If HITAC can take a more proactive leadership role in helping channel some of what's already moving.
Well, we would love to come back to the policy board as we get into our exploratory work and tell you what we think the right focus areas are and get feedback from you all. Would that make, so you should think about whether you'd like to have us back. It's a big world. There's a lot of possibilities for health IT to add value around social determinants of health. And I think we've already had some themes arising. We'll have some more as we go. But I would say mid-year we'd be able to come back and say, this is where we think the real bang for the buck is.
Send me a note if you want some MPH students to help you out. Be a great project to see what's out there.
Yeah.
And you're thinking, is health equity a subset of social determinants?
It is, yeah.
I think in CCO 2.0, we've been consistent-ish in trying to use the phrasing social determinants of health and health equity.
Okay, right.
So that might be worth specifically calling out so people can see it.
So Susan, this is Carla. Just always so impressed with the work that your group does. Just really feels like you have accomplished so much, and really like the direction that you're headed. So thank you for the good work.
Thank you.
John, had a comment?
Yeah, since you all use the term dashboards and milestones, and earlier you mentioned that we are an Epic-dominated state. Another thing I think that vendors could do is give you data. You get the permission of all the Epic customers in Oregon for Epic to give you either organizational identified or de-identified data. And you can start to see, well, how many notes are being shared? How many notes are being opened? What's happening across the state? Maybe you can call the folks up in British Columbia who I think are implementing Epic across the whole province. How does Oregon compare to Epic elsewhere, if they'd be willing to do that? And then of course, eventually the other vendors, they need to have some consistent definitions and metrics, so that you could get a sense of, well, how are Cerner organizations faring the same way, without identifying any specific, organizations. So.
Yeah, I know Epic has some interesting kind of summary data we've seen, at least from one system that shared some of that. It would be interesting to try and aggregate a bit of that together.
All right, well, thank you so much for the comments. And I think we're ready to move into our last section. Any other comments before we do that?
Just thank you so much.
Well, thank you so much, especially today. Thank you for coming.
So, Jeff, it looks like you're leading this discussion, is that correct?
He's rousing himself this direction.
Okay. So I actually think the work of High Talk, the exciting committee, they need a liaison. So something to think about.
Thanks, Carla. This is Jeff Scroggin, and I'm just going to talk a little bit about our committee liaison structure, diagram design, and some of the more information we added to this. And to the earlier point you made, I worked with Dr. Bangsberg and Dr. McKelvey on this, so if you have a tough question, I'm going to refer it to them for input as well, just to put you both on notice. Following the retreat, I kind of focused on two components for this: identifying the roles of liaisons better, and identifying the board's relationship to its committees, as well as the priority work. As you can see, I've listed the committees, and they're in acronym form, but below you can see the acronyms, and those are also links. You can go directly to the website for any of these committees by clicking on those links in your document. Healthcare Workforce Committee, Health Quality Metrics Committee, Health Information Technology Oversight Council you just heard of, and the Public Health Advisory Board are all statutorily under the Oregon Health Policy Board one way or another. Additionally, the board has statutory authority to establish committees that it sees fit and necessary, and has established the Health Equity Committee. So though that's not a statutory committee, it's listed on this diagram for your reference as the Health Equity Committee. I tried to show the board's priority policy focus areas that it consented on in the retreat last month by identifying them in green. So I've got children's health in a box, and healthcare cost sustainability, the benchmark work in a box. And then what I did was highlight the Health Equity Committee and Health Equity Measurement Committee that Leanne briefed you on earlier this morning in green, so that you can see the alignment between the board's priority policy focus areas and these committees. That's not to say that each one of these committees in blue doesn't also work on the board's priority policy committees. They just may also have other things that they're doing and not be established solely for those efforts. We put a box around this to be really clear that OHA staffs these committees for the most part and leads the staffing and coordination. So you are oversight over OHA's policy development, so you can see your role in that oversight with the Oregon Health Authority. I also put the Oregon Health Authority as the link between the children's health work and the healthcare cost sustainability work. I think this will become more fleshed out as we progress in the session, and as the work plans come forward. There may be bodies that are committees that are identified that we want to have liaisons to, or a group of liaisons to, but right now those bodies haven't been identified or established. And then lastly, I wanted to share that I have the Metrics and Scoring Committee on this diagram. Even though the Metrics and Scoring Committee doesn't report directly to the board, they work with the Health Plan Quality Metrics Committee, and it's a back and forth relationship, although I think in statute, the Health Plan Quality Metrics Committee has some oversight over the Metrics and Scoring Committee. I also wanted to really clearly show where the health equity measurement work is in this work. And you can see it's tied in through the Metrics and Scoring Committee, Health Plan Quality Metrics Committee, Health Equity Committee, and Public Health Advisory Board. And we do that by making sure that there are committee members on those committees in this committee, so that each one of those committees has some buy-in and members who are able to communicate directly about the work that's being done. So the work that Leanne briefed earlier this morning is that work. Is there any questions about the diagram?
Do you want to speak to calling out Early Learning Council?
Yeah, Early Learning Council is a public body that the board has been involved with in the past, and may do some joint meetings. We could have a presentation I think we talked about and share some of the work doing that. But I didn't want to say that the Early Learning Council is staffed by the Oregon Health Authority. We work with the Early Learning Council, but obviously it's not staffed directly by the Oregon Health Authority, so it's kind of off to the side there in a kind of coordinated fashion. And I assume that that will be a key component of the Children's Health work plan.
I was going to say, it would be fair then to say that linkage is called out because of the children's health emphasis. There are other similar indirect linkages that aren't called out because they're not key to one of the board's priorities.
Very much so. There's lots of those.
This is John. I do think eventually there will be a measurement piece in the healthcare cost.
Oh, yes.
And it'll be a really important piece. You know, you've kind of dealt with that well in terms of the equity, how you did equity. Eventually, there's going to need to be that kind of thing, dotted lines connecting cost to the measurement processes that are going on.
Absolutely. I think that's right. We'll have arrows and dotted lines. I'm going to flip it over unless there's other questions about the diagram.
Next time it'll be printed out on 3D printers.
Yes.
Planetary.
Well, I would just comment, there's yet an even more expanded version of this that we've used with some of our legislative committees that then take the OHA side and blow it up to its relationships with coordinated care organizations, local public health authorities, community mental health agencies, all those kinds of things to really sort of try to show graphically the whole web of how the work gets done from a policy to delivery standpoint.
And we can share that graphic with the board. The only other thing I had mentioned about the first page is we tried to list the current liaisons there, and you can see there's some to be determined, not applicable. Flip it over, I worked with Carla about Dr. McKelvey on this, and she and her role as the liaison to the Healthcare Workforce Committee, and Mark Overbeck as the lead staff for that committee on what would be some improved language for this section of the structure around what the expectations is for liaisons. And I won't read this verbatim, but I'll call out a couple of the key components. We usually try and use consensus to establish these. If you don't want to do it, you'd be the wrong person to do it. We want committee chairs and OHA staff to work with board liaisons to identify what works best for the board liaison in the committee. We didn't establish an inflexible structure because we think it's different by committee. What the Public Health Advisory Board is different, needs from its board liaison is different than what the Health Plan Quality Metrics Committee needs from its liaison, which is different than what the Healthcare Workforce Committee needs from its liaison. Some of the things that they need are similar. One of the things that's just logistical is meeting schedules that allow board members to take part. Committees of the board will work with board liaisons to determine a cadence and meeting schedule that works for committee members and the board member who is a liaison. We've written this not in stone, in black and white on this paper because we want to be really clear that the expectation is not that board members as liaisons are committed to some time commitment that they don't know about. The idea is that you'll be able to work with that committee to determine not just the substance of your participation, but also the logistical component of your participation. And most of the committees that this has worked well and has worked really well for our board liaisons. They've been able to determine when they should go and what the cadence of the meeting should be in a way that works for them. Some of the roles that the liaison should have in the bullet points are attend in person or by phone if needed, ensure a strong connection to the board's priority policies that they've identified in meetings, and do regular updates to the board regarding the committee that they're liaison, as we did this morning. and participate in some of the higher level deliverable planning for the committees, like a charter or the work plans, to ensure that those committees are addressing the board's priorities in their long-range planning. We have another bullet around providing other updates regarding anything of substance to the liaison with the chair. So there's always an opportunity for you as a board liaison to reach out to the chair of the board and say, I've noticed this, or I was wondering about this. The chair is open to hearing, I'm speaking for Carla now, any issues you may like to identify for the board's purview, as of course are all the staff. I think that's all I want to highlight on the back of this page. We used to have a structure where maybe there was a difference between a liaison and a quote-unquote monitor. I think that resulted in some confusion. What we've done is erase that monitor role and just say there's a liaison that's flexible to meet the needs of the liaison, the board, and the committee.
Given that I have a degree in liberal arts, thank you for getting all the way through that without using the word liaise.
Now I'm so tempted.
Right.
So I know that the board discussed at the retreat more identification of committees and a further description of these roles. And I do think at our next retreat, we can take a longer amount of time and potentially do a much more deliberative process around the liaisons. What we've continued to do since we established this structure is build it, and that's kind of what we're continuing to do. Add more definition and update the definition, and continue to, frankly, push board members towards liaison roles that they feel they might be productive in.
If I just add, my participation on FAB has been, I really enjoyed it because there's the two-way flow of information. Taking information up that occurs in this board down to FAB, say, hey, CCO 2.0 is happening. You know, it's time to get on board, to start thinking about this, and generated a bunch of discussion. And I think very vigorous discussion, and brought that vigorous discussion up here, very vigorously. And you know, I think that two-way flow of information is really, really important, both to set priorities for the committees, but also to bring that up for our deliberation.
So just provide one other update, if there are no other questions about the language in this. After having some back and forth with our former chair Zeke and Rosenda. Rosenda, are you still on the line with us? She might have had to drop off too. I think that there is a willingness for them to find a way to participate as liaisons for the Health Equity Committee. I think that their schedules are dependent. They want to make sure it really works, and they want to be clear about their roles and who is backup or who is primary. But I think that they're moving forward in those roles, so long as we can identify some of those things.
Well, and real specifically, we needed to figure out a different meeting date than the current one for that committee, right?
Correct, and I think we're gonna work with the Health Equity Committee to determine a date that works best for everybody. That said, I don't think we've had a lot more commitments for some of the other committees or some of the other roles and responsibilities, which is the tougher part of the conversation. Happy to turn it over to Dr. Vansberg and Dr. McKelvey.
So my question is the process when, Carla, David, by what structure are you thinking about helping line up the assignment for those of us who aren't tethered to a particular committee?
I think pick your favorite.
Yeah.
Yeah. And I think then work with the committee to figure out a time that makes sense to meet. You know, obviously if you're traveling, it's gonna be by phone a lot, and make sure it's a time that's convenient.
I think that's a good question. Before we get even further into the answer, I just want to check and see if Oscar is on the phone as well. I think he was on the phone at one point and wanted to see if he had a chance to review this or had any questions about it. Oscar, are you with us?
Carla, do you have guidance in terms of communications and?
So I have reached out to various people who have indicated interest, and I think with the Health Equity Committee that the big barrier has been the meeting time. So I think as soon as we resolve that, we have a liaison and a backup liaison. I think we probably have a backup liaison for the Healthcare Workforce Committee. So that primarily leaves High Talk, I think.
So it might be helpful, I think, to send out to the full board again the charters and then current meeting times and locations for each of the committees. That would just be a process question. Check.
Yeah, I'll do that.
And I think if somebody's interested in being the liaison, but the committee meeting time is a barrier, if they could let us know that, so we could see what we could do around that.
Right. The benefit to these committees all reporting to you statutorily or having created them is you have some role in how they meet.
Thanks for saying that out loud, yeah. That's helpful.
And I don't think we need to identify, there's a line in here that says it's the expectation that everybody serves as a liaison at some point, but given that there's probably 2 other bodies of work that are gonna come forward as work plans are developed, it may not be necessary to decide today who's gonna liaison for every single thing. I think Carla's right. The only one that's outstanding that maybe might be suited for a liaison role is the Health Information Technology Oversight Council.
So can we speak a little bit, and maybe this is to you, Pat, around the children's health or the healthcare cost sustainability around what you're envisioning, is a liaison the right function for staying connected with those 2 bodies, or?
That's a good question. At first blush, and subject to thinking more about it and having a completely different answer, it seems to me that the better structure is to be the liaison to the standing committees, to be able to bring to those committees, the pieces that come out of those bodies of work. Since I think those represent more bodies of work than they do organizational structures.
It sounds like High Talk's gonna do some really important stuff over the next year.
Question for Jeff on High Talk. Or maybe it's just that it relates to High Talk, but it's the nature of being a liaison. Do you believe that the role of a liaison inherently leads itself to a place where there could be conflicts of interest, or because it's a communication role, is that less likely to be a challenge?
I think it's less likely to be a challenge. Susan, do you have a take on it?
Since I'm here, I'll just mention for High Talk, what we've really enjoyed when we had a liaison was having someone talk about what's happening at the board, so give the debrief from what's going on at the board, and then really caring or thinking about health IT during your board meetings when you're meeting. Because health IT is something that can support all sorts of parts of health system transformation. And it's something that folks don't think about or think about later or assume there's technology in place. So what we found is just having somebody, our liaison, keep health IT in mind as you're hearing from other committees or you're thinking about other work, can really help us make those connections. We certainly try and track what the board is doing. We had our liaison, we had a half an hour check-in meeting with that liaison once every other month ahead of our High Talk meetings. And she was often unable to attend in person. She'd call in, or we would talk in that pre-meeting about what parts of that meeting were really important for her to stay on the phone for if she had other priorities. So I think for High Talk, I think it's a low lift in terms of being the liaison. Again, when we're talking about exploring social determinants of health, I think our High Talk liaison could be bringing that update to you all and saying, here's what we heard, at High Talk and where we think we might be going.
Aren't the board representatives ex officio members on the subcommittees? I know I'm ex officio on FAB. Maybe that's, I'm highly conflicted.
Amy non-voting?
Yeah. Clarify that last. Non-voting ex officio. Maybe that's
right.
because I'm highly conflicted
right.
as a public health dean.
Right.
So highly conflicted for public health.
I think you're correct.
So Oscar apparently is on the phone, but he's on listen only mode. So he sent me an email, so I'm going to share that with you. He has 3 points he'd like to make. One is it would not make sense for the Health Equity Committee to have its upcoming retreat without a board liaison who can participate. Number 2, it might be good to consider having an OHA staff member also be part of the Health Equity Committee and not just OEI staff. I thought we did have an OHA staff member on that. But anyway, number 3, I would be happy to continue engaging with Health Equity if the meeting time for Health Equity could be revisited to meet my schedule.
think yes to the first two, no problems for that. We'll take a look at the third one and talk to Oscar and maybe sort out what the meeting schedule opportunities be for both of them. We don't have to land these for all of these today either, but did want to.
But it'd be really good if we did.
At least maybe the high top.
Do we not have an OHA staff member on the Health Equity Committee?
We have OHA staff who staff the committee.
Okay.
Yeah, I would need to understand that comment a little bit better than I think I do.
Either John has a question or he's volunteering for High Talk.
No, I want to make a comment. I just think for the record that HB 4005 included a representative of the Oregon Health Policy Board. I think that's going to continue through 2019 and into 2020. At the final meeting, they made it clear we're going to reconvene and keep going. I really love doing that, and I would want to continue doing that. And you know, there are these interim and limited things that come up that I'm happy to help with, because you know, I'm a part-time worker and in Portland. So those are fun things, and I mean, they maybe shouldn't be in here, but you need to keep those in.
Just sort of be clear, so we're really the only gap we have to fill today is High Talk, right? I mean, the cost piece, we're not really sure how that's gonna all pan out in terms of structure. You know, children's piece is a body of work that we still need to kind of work on what the agenda is. So is it just, I'm trying to call a question here, is it just High Talk that we're trying to
Yeah, and we can do
filter?
it tentatively, you know, meet with High Talk and see if it's a scopes out or something you're interested in. You don't have to make a firm, absolutely, I'll do this.
I don't know, I tried to open the barn door as far as I could, and the horse wouldn't go through it, so.
We can go, you might as well.
I want to learn more, actually, yeah.
Kirsten, what do you think?
I can give it a try. I just don't feel like it's an area where I bring a lot of. Anyway, I can give it a whirl.
I don't think it requires a lot of content and expertise in that it's really a communication function. Especially it's like High Talk's going to be talking about social determinants of health. It's you know, it's really, you know, helping sift through that conversation and bringing that to the board. Rather, I mean, is that right?
Yeah, absolutely.
You're not going to ask someone to code, right?
No, there's no coding required. And, you know, we've developed a great orientation materials for our new High Talk members, so there's a lot of stuff already ready. High Talk meets every other Thursday, first Thursday of every other month from 12:30 to 3:45 here in Portland, downtown. So that's our schedule. So we're meeting on February 7th, so Thursday this week.
I'll just say it out loud in case this is what some of the people are thinking about. I know there's a lot of interest among the board in terms of the cost work, and I know at least 4 people have said, kind of want to hold my seat for that, and I think we just have to have a giant Rochambeau tournament at some point in July if we decide we need to like do liaisons, but I think we can make adjustments as the year goes on if we need.
We try to put it in here explicitly as well. You can be a liaison to more than one.
Yeah, I think for me personally, I have a lot of interest in a lot of these areas, and it's really about the commitment and the time, and once I commit, I'm all in. It's just a matter of trying to make sure the logistics work, yeah, so thank you.
So do I hear we have 2?
Hi, this is Oscar. Can you guys hear me now?
Yes.
Yeah.
Oh, Oscar, yay! Figured out technology. So I was cutting in and out, so I apologize if I kind of dialed back in, so I'm sure I missed some of the conversation. I did hear that Carla relayed in a pretty high level my thoughts, which are more connected to the Health Equity Committee, and it sounds like you guys are referring more now to High Talk. So, but just to kind of give a little bit more context about what I was trying to convey through email, through Carla was, you know, really kind of making sure that we didn't move forward with having the Health Equity Committee do its retreat. I know I saw that on the notes coming up soon. I didn't really see a date, but based on just checking in with one of the co-chairs, it sounds like it's coming up in March, in early March, and I just want to make sure that we have a liaison that's established and that is going to be able to attend and participate because I think it would be a really missed opportunity if the Health Equity Committee spends, you know, a full day doing this retreat without that board liaison. So making sure that we work to connect that. As far as my other point about making sure that there's also that connection between the OHA staff, it sounds like that is happening. I appreciate that. It's been a while since I've been able to attend one of the Health Equity Committee meetings just because of my scheduling conflicts. So I'm glad that's happening, and I would continue to sort of, you know, advocate that that is happening to make sure that there's progress that's being moved, and that it's not just on the OEI side, but it's also connecting back to the OHA side. Yeah.
So maybe that's the, just, Oscar, this is Pat, maybe that's, I think of OEI staff as OHA staff. So what you saying, maybe if I could rephrase what I think you're saying is, in addition to OHA, OEI staff, you'd also like OHA policy staff involved?
Yes, yeah, I do think that, I mean, to me, I know that OEI staff is OHA staff, but it does kind of feel that there's this kind of feeling that it's a little bit separated. And I really want to sort of make sure that there is that integration between both divisions.
Okay.
Really helpful for us. So what I heard was Kristen would consider the high talk thing after doing some more exploration, but there's no commitment. She's nodding her head yes.
Yeah.
Boy, that's not the way I would have rephrased that.
Yeah, I heard Brenda also. I think we got 2 high talk people who are up for consideration.
Yeah. I mean, I'd be happy to respond back to Carla, to you, Jeff, whomever, within the week or so once I get more details.
Okay, sounds good.
Yeah.
And you know, I'm willing to help out if you can't make it. I do think I have a conflict. Open Notes has gotten grants from the state in the past. I think Beth Israel would want to find out more.
I tried.
So we'll work with the chair and vice chair and the folks who've identified themselves as interested in learning more information. Thanks so much for your time.
All right, thank you.
Thanks.
Okay, so we have about 3 more minutes left for any last thoughts or comments.
No hands raised here.
Go ahead.
Oh, no one's raising hands.
Okay. Our next meeting is March 5th. Same time, same place, hopefully without the snow and ice. For everybody who's traveling today from the meeting, please be safe.
Thank you.
Thank you.
Thank you.
Bye-bye, Carla.